Good morning, ladies and gentlemen, and welcome to all the participants to our stellar lineup of brilliant moderators and exceptionally astute presenters. Representing the Minister of Health and Wellness this morning is Dr. Nadine Williams, Director of Health Services and Planning and Integration. We'd like to welcome her. Welcome to all the medical professionals who are on board with us this morning at the symposium. I'd like to thank our many sponsors. Thank you very much for our sponsor this morning. The title sponsor of this morning's and today's symposium is the National Health Fund. And of course, our gold sponsor is IPCA Laboratories, the silver sponsor, Wysinco, Dr. Reddy's, and CariMed. So once more, I'd like to thank all these sponsors without whom this event would not have been possible. So that's National Health Fund, our title sponsor. I'd like to thank them very much for coming on board. And they have been on board with us for the last 2 or 3 years. IPCA Laboratories has also been with us as well. We thank them very much. And of course, Wysinco, Dr. Reddy's, and CariMed. I'd like to welcome you on behalf of the Lupus Foundation of Jamaica and all our members to the second virtual symposium, and I think the 6th overall, to greetings to all our lupus warriors, their families and friends, and greetings to all other participants and guests online. We have crafted a program rich with information from leaders in the field of lupus research and patient care, both locally and internationally, complemented by exciting, though thought-provoking discussions. I therefore invite you to buckle up and prepare yourselves for an amazing couple of hours of learning, insights, and of course, yes, the new developments and entertainment.
Recording in progress.
Ladies and gentlemen, good morning. Welcome to the second virtual Lupus Symposium put on by the Lupus Foundation of Jamaica. Welcome to all our participants and welcome to our stellar lineup of brilliant moderators and exceptionally astute presenters. Welcome to the Minister of Health, and representing the Minister of Health and Wellness this morning is Dr. Nadine Williams, Director of Health Services Planning and Integration. Welcome as well to all the medical professionals who are on board with us for today's symposium. Thank you to our sponsors, without whom today's event would not have been possible. Our title sponsor for the symposium this year is the National Health Fund, and our gold sponsor, IPCA Laboratories, silver sponsors, Wysinco, Dr. Reddy's, and CariMed. I'd like to thank you once more very publicly for being on board on this really great occasion of extremely good learning and insights that will be shared. So I'd like to welcome on behalf of the Lupus Foundation of Jamaica and all our members to our second virtual symposium. Greetings to all the lupus warriors and their families and friends. Greetings to all other participants and guests online. As I might have mentioned before, we have crafted a program rich with information from our leaders in the field of lupus research and patient care, both locally and internationally. Of course, complemented by exciting and thought-provoking discussions. I therefore invite you to buckle up and prepare yourselves for what I'd like to think is an amazing couple of hours of learning, insights, new development, and yes, entertainment. Yes, there will be entertainment. The journey of increasing our public awareness of lupus begins now. Once again, I'd like to thank our sponsors, the National Health Fund, who are our title sponsors, and our gold sponsors, IPCA Laboratories, silver sponsors, Wysinco, Dr. Reddy's, and CariMed. At this time, I'd like to invite Reverend Verna Cassells, board member and chaplain of the Lupus Foundation of Jamaica, to lead us in prayer as we begin this program. We ask for all persons in reverence as we prepare in prayer for this event. Reverend Verna Cassels.
Let us pray. Thank you, Lord, for the Lupus Foundation of Jamaica as we celebrate our 37th year of activities. We pray your blessing on the board members headed by President Dr. Desiree Tollereed, most of whom are not afflicted by lupus, but all of whom demonstrate dedication to work for those who are. Gracious God, we are ever so grateful to you for the activities of this year's Lupus Month 2021, focusing on children and youth under the theme Children and Youth with Lupus, Improving Outcomes through Knowledge and Support. And so, glorious God, we praise you for the success of all the activities we have been engaged in throughout this month, including the launch, the church service held at St. Margaret's Anglican Church, Laps for Lupus, interviews, news items, Lupus support group presentation, personal testimonies, and others, culminating with the annual Lupus Month Symposium. Affirming God, we pray that you would affirm the presenters to impart the knowledge effectively and clearly. Into your hands we present this event and submit ourselves for the impactful experience as we pray your enabling for a successful follow-through. Healing God, now we pray particularly for all our lupus warriors, that you may transform our pain into healing, or sorrow into joy, or loneliness into support, or weakness into strength. This we pray in Jesus' name. Amen and amen.
Thank you, Reverend Verna Cassels. I know that we're definitely now off to an excellent start with that prayer and blessing that you have offered for us. Thank you very much, Verna Cassels. At this time, I'd like to introduce our president of the Lupus Foundation of Jamaica, a noted rheumatologist, Dr. Desiree Tollereed, who will be bringing the opening remarks of this, our second virtual symposium. It's my esteemed pleasure to invite Dr. Tollereed, who will now open with her presidential remarks. Dr. Tollereed.
Thank you, Mr. Smith. And of course, for protocol, we do thank our Master of Ceremonies, Mr. Pete Smith, Dr. Nadine Williams, Director of Health Services Planning and Integration Branch in the Ministry of Health and Wellness, representing the Minister of Health and Wellness, our special, very special keynote speaker, Professor Earl Silverman, Professor Emeritus, University of Toronto, all our other distinguished presenters and moderators, our sponsors and representatives of our sponsors, particularly our title sponsor, National Health Fund, our board members, particularly our President Emeritus, Dr. Carol Lakula, and other board members, and not at all least our health professionals, Lupus Foundation members, patients, members of the public in the room and watching on our streaming platforms. We have always had a symposium every year, but this one is a particularly of importance because its focus is on our young people. Young people are our future, and we want to make sure they are strong and healthy as we have them take over from us older ones take us into a bright future. Our annual Lupus Symposium, which for the second time is being staged in this platform as a virtual platform. But as always, traditionally, it uniquely provides both continuing medical education for a range of health professionals, while also incorporating subjects of practical interest to patients and the public in a shared learning environment. We hope that we've been successful this year in extending that shared learning environment to our young people as we seek to hear from them, engage them, and speak specifically to the issues that they face, all with the objective, as the theme goes, of improving outcomes. And so this annual Lupus Symposium represents the culmination of a month-long public awareness campaign that has engaged the public and especially young people in raising awareness, reducing stigma, and encouraging greater support, particularly for this vulnerable group. And we hope that you will be empowered with the latest knowledge of diagnosis and management, but also with the practical ways that we can help support this special group. And I want to say how grateful we are, especially to our special guest, Professor Earl Silverman, who kindly consented to join us today and will be presenting the keynote talk and will set the stage for this symposium as we focus on this theme of outcomes for our young people. I'd also note that the Canadians have been very special to us in a number of ways. And in particular, the Canadians have largely been responsible by contributing in a large part to the workforce of specialists that are available in Jamaica today to care for our patients with lupus. Many of us, Professor Silverman, have come through your hands, and we look forward to extending the work in Jamaica and also to a growing relationship in the future. And so as a foundation, the Lupus Foundation of Jamaica, which is a volunteer-run, member-based charitable organization that's been in existence since 1984, we've been dedicated to improving the lives and outcomes of persons with lupus through information, support, advocacy, and patient-centered research. And it is our hope that through the information and perspectives presented today by our experts, as well as our warriors, that we will all be equipped to join the fight against lupus and to win. Thank you.
Thank you very much. Thank you very much, Dr. Tulreed. And I'd like to thank as well the guest speaker, Professor Silverman, for being here. I am very much anticipating his presentation. And of course, again, I'd like to welcome Dr. Nadine Williams, who is representing today the Minister of Health and Wellness in her capacity as Director of Health Services Planning and Integration Branch. So we're now off to what I think is a really great start. And I'd like to just have a few housekeeping matters dealt with. We ask all participants to remember to place their phones in silent or vibrate so as to prevent any interruptions on your side. And yes, remember to mute your mics at all times unless it's time for you to speak. So Before I go on actually to sort of whet your appetites as to what is to come, I'd just like to let you know that one of the features of this morning, or today's symposium, that we're going to have a very brilliant set of moderators. And I'd like to take the opportunity to just sort of introduce you to a couple of them, and you will be seeing them as the program goes on. I'd like to first introduce and to let everybody be aware that Dr. Tanisha McGee Phillips, consultant rheumatologist from the Cornwall Regional Hospital, will be one of our moderators. Dr. Lorian Fisher, consultant nephrologist from the University Hospital of the West Indies. Dr. Raquel Lowe-Jones, consultant nephrologist also from the Mandeville Regional Hospital. And of course, Dr. Karel de Kula, President Emeritus, consultant rheumatologist. I would like to indicate that at the end, we will have Miss Pivette Swaby, educational psychologist from the Ministry of Education, Youth and Information. However, at this time, I would love to have all attention paid now to Dr. Nadine Williams, Director of Health Services and Planning of the Integration Branch of the Ministry of Health and Wellness. Dr. Nadine Williams.
Mr. Master of Ceremonies, Mr. Pete Smith, President of the Lupus Foundation of Jamaica, Dr. Desiree Tully-Reed, Reverend Verna Cassels, specially invited keynote speaker, Professor Earl Silverman, other speakers and moderators, officers of the Lupus Foundation of Jamaica, distinguished guests, volunteers and sponsors, gentlemen, members of the media, Lupus warriors young and old, good morning. It is my pleasure to be here, and permit me to offer an apology on behalf of the Minister of Health and Wellness, Dr. the Honorable Christopher Tufton, who is regrettably unable to join us this morning. Jamaica is considered to have a high prevalence of this disease called lupus, with an estimated 6,000 persons being affected, or perhaps more. Lupus most commonly has its onset among young women, but individuals of any gender or age can be affected. I wish to offer my highest commendations to the Lupus Foundation of Jamaica, which has provided its members with access to pharmacy discounts, support group meetings, and health professionals for over 30 years, in addition to the ongoing efforts to increase public awareness of the disease. The government's commitment to universal access. The government of Jamaica is committed to universal access to healthcare. Among the services to which we have succeeded in giving Jamaicans enhanced access is the pharmaceutical service. Jamaicans now have the benefit of 105 fully operational DrugServe locations, which is up from 17 3 years ago, and 49 public-private sector pharmacy partnerships, all managed by the National Health Fund, the NHF. The expansion of these services has meant that the average wait time for filling prescriptions is now under 1 hour, down from an average wait time of 3 to 4 hours in 2017. This is an example of universal access. The NHF is also estimating that 2.5 million prescriptions are to be filled by the public health system this year, up from 1.5 million in 2018. More Jamaicans are accessing free drugs under an expanded network and a more efficient distribution system. With respect to the government's commitment to fight lupus, the government of Jamaica has stood out in its commitment to improving the outcomes of persons affected by lupus by providing specialist health care and vital drugs free of cost through the public healthcare system, and now to have drugs available in the private system subsidized by the NHF. It is to be especially noted that the Ministry of Health and Wellness, in accordance with the WHO, the World Health Organization's interim guidelines, which was published on October 26th, just this week, on Tuesday, approved the provision of an additional dose of the COVID vaccine in the primary series of vaccines which are approved under the WHO's emergency use listing for those deemed immunosuppressed. This list of persons includes those with active cancers, but also includes those who are on chronic dialysis and those who are on immunosuppressants. The relevant vaccines at this time in Jamaica are the AstraZeneca and Pfizer and the Johnson & Johnson vaccines. Such a move will certainly enhance the protection of more persons living with lupus within the context of the current COVID pandemic. We are all here to play a part, and we all have to play a part in supporting the initiatives that improve the awareness and understanding of this disease, as well as the outcomes of those living with lupus. I implore all Jamaicans to join together in this lupus fight. Again, please allow me to say thank you to the Lupus Foundation of Jamaica for its hard work and all that you have been doing. I look forward to an even greater collaboration. It is therefore with the greatest pleasure that I declare this virtual symposium, which is themed Children and Youth with Lupus, Improving Outcomes Through Knowledge and Support, opened. You certainly have the full endorsement for a successful symposium from the Ministry of Health and Wellness. I thank you.
Thank you very much, Dr. Nadine Williams. And thank you very much for that endorsement from the Ministry of Health and Wellness. Please convey our thank you to Dr. Christopher Tufton, the Minister of Wellness, of Health and Wellness. We do appreciate it, and we do recognize that there's an immense amount of work being done by the ministry. So thank you very much, Dr. Nadine Williams. It really is good seeing you once more. We will definitely have our chat after. I'd like to once again at this time thank our title sponsor, the National Health Fund, who you heard about playing a very key and critical role within the health space of Jamaica, not only in providing medication and the whole logistics. They are the title sponsors of our symposium. And of course, our gold sponsor is IPCA Laboratories. Silver sponsors include Wysinkel, Dr. Reddy's, and Carimed. So, and we'll tell a little bit more about these sponsors without whom today's event certainly will not be as successful as it is. So again, once again, thank you very much, Dr. Williams, and thanks to the Ministry of Health and Wellness for your continued support and endorsement of this really important symposium. So we will be moving into one of the other segments that will tell a little bit more about the National Health Fund, but I'd like to at least bring to your attention the fact that we have a Q&A fixture really, which allows persons to ask, a Q&A button that allows persons to put questions to the presenters. And our moderator will be coordinating this aspect of it, but I thought that we'd best bring it to your attention so that by the time things get going, you'll be fully aware of all the features that are going to be required. The symposium, as I indicated, will be moderated by a number of brilliant doctors in their own rights. I would just like to mention that as we start off, the list of moderators actually going to be kicked off with the contributions from Dr. Tanisha McGee Phillips. But before we get to Dr. Phillips, I'd like to bring a quick word from the from the National Health Fund, actually. So as we prepare for the moderators that will be coming on stream very shortly, but the National Health Fund, as we had indicated, has actually been very integral in terms of providing extremely important and critical medication for our lupus warriors or lupus patients. And as you indicated, with the current pandemic, we have the National Health Fund carefully coordinating logistics of all the vaccines that we currently have. So they are playing such an integral role that certainly we're extremely grateful to them. Now, the thing is, we recognize that we will have some time constraints. So there are going to be some aspects that we will be stepping up in terms of moving very quickly. So work with us on this, and let us take the opportunity to at least recognize that the entire event, which is actually streamed across the world, actually, is one where we expect the same level of engagement and, not to mention, enlightenment, as Dr. Tullery had indicated. It's a really rich event in terms of information on lupus care and lupus management, and we anticipate that you will be benefiting immensely from this as well. Right, we will be giving you a quick insight, a quick video on the National Health Fund. So stay with us before we get started with our moderators, and we will be introducing Dr. Tanisha McGee-Phillips, the consultant rheumatologist from the Cornwall Regional Hospital, right after. So stay with us as we watch the National Health Fund and some of the work that they do. Right, so good morning again, and welcome to session one, where we will get things started at this very exciting moment. We'd like to introduce Dr. Tanisha McGee-Phillips. Dr. Tanisha McGee-Phillips is a consultant rheumatologist from the Cornwall Regional Hospital, and she will introduce a number of our brilliant presenters within the same field of medicine and in the area of lupus care and lupus management. So Dr. Tanisha McGee-Phillips, welcome and good morning to you.
Morning. Good morning, good morning, good morning, everyone. Good morning, good afternoon, good evening, wherever you are in the world, greetings. It is my honor and pleasure to be your moderator for the first session this morning. A special greetings to our lupus warriors and especially to the children and youth amongst you. Who better to talk to us about outcomes in pediatric lupus than Professor Earl Silverman, Professor Emeritus, Pediatrics and Rheumatology, University of Toronto, Editor-in-Chief of the Journal of Rheumatology. Professor Silverman undertook his undergraduate training between 1972 and 78, where he received his Doctor of Medicine at the University of Toronto in Canada. He went on to then do postgraduate research and specialty training in multiple countries. First, he was a resident in pediatrics at the Hospital for Sick Children in Toronto. He went on to be a registrar in pediatrics at the Children's Hospital in Melbourne, Australia. From there, he went on to be a fellow in pediatric rheumatology and immunology at the Children's Hospital at Stanford, where he also was a research fellow in the Division of Pathology, Cellular Immunology and Laboratory in 1984, when he concluded that stint. Now, Professor Silverman is known all across the world, the rheumatology world. He is the recipient of multiple awards, and I'll just name a couple of them. The award for excellence in clinical teaching from the Department of Pediatrics, University of Toronto, the Hospital for Sick Children in 2008. The Canadian Rheumatology Association Distinguished Investigator Award in 2010. And notably, he was the 2014 recipient of the Excellence in Investigative Mentoring Award bestowed by the American College of Rheumatology, the ACR. This honor recognized his outstanding contributions and mentorship in the Division of Medicine at the University of Toronto. In his role within the mentorship program, Dr. Silverman oversaw trainees in their academic pursuits, guiding them towards academic productivity and success. Professor Silverman has been the editor-in-chief of the Journal of Rheumatology since 2013. The journal, based in Toronto, Canada, founded in 1974, is one of the first journals dedicated to rheumatology. Now, with a background in clinical and laboratory research, Professor Silverman has been steering the Journal of Rheumatology towards being the leader in publications regarding all clinical and translational aspects of rheumatology. And the journal is a supporter of pediatric rheumatology research. He himself has over 500 publications in peer-reviewed journals. Now, over the past 5 years, Professor Silverman has run a young adult clinic for graduates from the Sick Kids Lupus Clinic for those between the ages of 18 and 22 years. And he does this in collaboration with an adult rheumatologist. And this is a new model for transition, an area that really does present itself as an area of unmet needs all across rheumatology. So we are greatly appreciative and honored that he took the time out to be our keynote presenter today on the topic of outcomes in pediatric lupus. He's eminently qualified to speak to us on this topic today. Professor Silverman, thank you and welcome.
I'm not sure how I can do anything after that, but I will try to do my best. And it's lovely to see some familiar faces. Dr. McGee Phillips, Dr. Tulloch Reed, I certainly know them well from Toronto. And I just want to thank them for inviting me. And and I really think it's a pleasure to talk about what I've been doing with my life for the last 35 some odd years, and particularly in the last 5 to 7 years since I have officially stopped work, officially retired, I guess is the best way to put it, from the University of Toronto at Sick Kids. And now I really spend only seeing lupus patients, which I've now done, as I said, for the last 10 years, and have now looked into looking at the long-term outcome as we've devised this clinic where I follow 18 to 20-year-olds with an adult colleague who will then be taken over, their care will be taken over by my adult colleague, we hope for many, many years to come. And with that, I'd like to start my talk. Now let's see. Okay, let me go back to the beginning. Can you see that? I am really terrible at this. Can you see the screen? Okay, so are you seeing me or are you just seeing, okay.
We're seeing you.
Okay, so let me try to then get you the talk. Okay, hang on for 2 more seconds. Okay, I will put this up in a second. And now, can you see the talk? No. Okay, that I just don't understand this advanced sharing. So it worked well before. Okay, I see myself, but if somebody can just comment into the comments whether they can see the talk or not. Can you see the talk or are you seeing me? Tanisha, can you see the first slide?
I'm seeing you, Prof. Prof. Silverman, not
okay.
yet.
All right, let me try one more time, and I do apologize. Oh, there we go. Okay, I'm sorry. How's that?
Great.
Okay, so
fabulous.
after that delay, I do appreciate your time, and we'll move along. So I'm just going to quickly, come on, there we go. With a quick case, just to show you a couple things. It's a 4-year-old girl of Indian descent from the Indian subcontinent, who had a really sudden onset of disease, was completely well until 4 weeks before we saw her. She developed a sore throat, otitis media. And of course, everything in pediatrics is infectious. We usually say it's caused by a virus. In this case, they felt it was bacterial. Then she developed the rash over her cheeks. Then she developed joint pains, and then developed a diffuse swelling over her arm where she had a previous blood taking. As I said, she was completely well until a month before we saw her, never hospitalized. Family history, no autoimmune disease, just some anemia. My brother, and her physical exam showed for a 4-year-old pretty good. Her blood pressure was okay. She had fever. She was tachycardic. She had an obvious facial rash, ulcers on her hard palate. She did have a cellulitis on her arm, and she did not have any active joints despite the pain, and the rash was pretty obvious of the classic butterfly rash of lupus. And interestingly, her cellulitis was pneumococcal, which we know people with lupus are at increased susceptibility. So quickly going through this, just so we're all on the same page, we know it's a multi-system inflammatory disease. There are multiple autoantibodies that are present. It has exacerbations and remissions, which seem to run in many times a course of their own. There is immunoglobulin deposition, occasionally true vessel wall inflammation, and a classic interplay of genetic environmental factors. And the question you always get, especially in pediatrics, is why now, why me? And this is where the environment and the genetics come into it. So in pediatric, how many patients get it? Well, approximately 20% of all cases begin less than 18 years. Not all countries use 18 years as a definition of child or pediatric onset disease. Some use 16, and some countries go down as low as 14. And some of my American colleagues actually see patients in, quote, pediatric clinic up to 22. But 18 seems to be a pretty good cutoff. The overall prevalence of the disease is about 10 to 20 per 100,000 people less than 18, but this is in a white or Caucasian population. An estimate from China said the prevalence was 6.3 per 100,000. I'm going to get to that in a minute later on. When I talk about China and outcomes, their incidence, they said, was less than 1 per 100,000 per year. As you can see, the data is actually pretty scarce. It's really hard to get. Some of the biggest demographic studies, such as population-based studies from Mayo Clinic and other true population-based studies, are hard to get for lupus. And we know for sure it's more common in non-Caucasian populations, including native populations in North America, in Australia, New Zealand, and in South America, and certainly in people from the African continent. But again, Africa, as I've been told many, many times, is not a single continent, and which an amazingly diverse genetic background. So it is more common in males than in females and adult, and it may look impressive, 4-to-1 versus 9-to-1 in adults. But remember, that's really only the difference between 80% and 90%. So yes, it is slightly more common in male, relatively more common in males and females, childhood onset. And I will use that word childhood onset because a lot of the studies, especially that I'm going to talk about, are into adulthood. So that's how we can distinguish the two, is childhood onset versus adulthood onset. Average age, depending on the series and how you die, what age you follow patients to, is somewhere between 11 to 14 years. And as I said, interestingly, in Toronto, in some racial or ethnic groups, if you have a adolescent, post-pubertal adolescent female, lupus is actually more likely to be the cause of their polyarthritis than JIA. Okay, sorry. So this is some data just to show that there was a lot of discussion of what's the effect of hormones versus non-hormone. And really, this is data from Toronto really showing that there really is no difference between the two. So there's approximately the same amount of males and females. I apologize for the top where the total in the males don't occur, but you can see that there's approximately the same number. Damage over time was about the same. So really, the difference is not impressive between them. So really, the constitutional features are very common in lupus. You all know there's no difference between pediatric and adult. I'll go through these quickly. Here's the classic rash, again, crossing the nasal bridge, sparing the nasal folds. I show you the same boy, again, on the right, showing that despite the impressive rash, it doesn't scar. I won't go much into cutaneous as there are talks on that. But there are classically oral ulcers, tend to be on the hard palate and along the buccal mucosa, occasionally on the inside of the lips or the tongue. Discoid lesions are seen, and there is some vasculitic-like lesions on the palms and the soles. One thing I learned was always look at the ears for the disease. Musculoskeletal features you know about. It's a pain. The difference between adult and pediatric lupus is that it can be painful in pediatric patients, but in probably approximately 50%, it is not. Unlike adult lupus, it is rarely deforming, so-called Njeku's arthritis is rarely seen. Myositis is rare. Other bone, more common, in fact, unfortunately, is avasonecrosis and osteoporosis. Renal disease, I'm going to go over quickly. Again, it's usually nephrotic. You can frequently detect the renal signs without clinical disease. Most pediatric patients, at least in our clinic, are not uremic, and most are not nephrotic, but again, it's time to diagnosis. The American College of Rheumatology only lists 2 criteria, their classification criteria, but it's known that it can affect many, many other parts of the nervous system. And particularly important, it's cognitive dysfunction and headaches. But I'm going to move over that quickly. And as you can see, this is, again, data from Toronto showing really, it's a busy slide, but it's just showing you that most patients have an overlap of their symptoms. So psychosis, cognition, seizures with anything. And chorea can be isolated, but can occur with others. Just want to go over this for too quickly, and that in many countries, in a pediatric patient who presents with chorea, it is more likely secondary to antiphospholipid antibodies than it would be to Sydenham's chorea secondary to streptococcal infection. In pediatrics, childhood onset, unlike adult onset, most patients with antiphospholipid antibodies, it is associated with lupus and not primary, and usually the chorea is bilateral. So now we're going to talk about what you asked me to talk about, and that's really outcome. So what factors are associated with outcome? And as I said, the age and the definition may differ, and age of onset may have some effect. The country that the reports are from today may or may not be related to the ethnicity in that country. If you take a country like Canada, where we are multi-ethnic, multiracial, and in Toronto, where Caucasians are now less than 50% of the population, ethnicity still may play a role. Importantly is access to medical care, and it was nice to hear from the ministry. Improving access to care is a high priority. One of the important things, and I think, is awareness of childhood onset lupus. I'm not going to show you data, but it's certainly when I started the clinic, we had 35 patients. This was a combined renal and rheumatology clinic. And I forgot to mention, it's great to see nephrologists present, because I think all renal disease in lupus is best co-managed in a combined clinic with a rheumatologist and a nephrologist, and we should all defer to the other ones on where our expertise is. But over time, we had it twice a week. And although Toronto increased its population and increased its diversity of its population, I think as the clinic was known, people became more and more aware of childhood onset lupus. And currently, we see 50 to 60 new patients a year. And we, quote, graduate 50 to 60 new patients a year to our transition clinic. Outcome is related to the organ involvement, and importantly and frequently overlooked is the patient factor of adherence or compliance to medication. Anybody who deals with young adults and adolescents knows how important the steroid-induced side effects are to this population, particularly female, as it is a disease mostly of females. And as you get older, we all know that adolescents and young adults know they're invincible and the disease won't harm them, that it may harm other people, but not them. And this is huge. And I think that the number one cause of medication, so-called failure to induce and maintain remission, is the lack of constant medication that we recommend. Right or wrong, that's what we recommend. And we always have to take that into account. And many of our long-term studies really, or all of our long-term studies really do not make any comment on did the person actually take the medication. And I'll show you data to show how important the medications are. So I want to look at this slide to show you what I meant by country. So you can see that the male to female ratio, so the age of onset actually are pretty consistent, except the outlier is Iran. And that's because the cutoff is 14, I think, in Iran. So again, the younger the cutoff for calling it childhood onset lupus, obviously, the lower the mean age. Amazing to me is again, it looks really big, the range, and it is, because you're really going from 3.3, which is amazing. And I don't believe it's because they're younger, to in India, really almost the 11 to 1. So this may be recognition. If you believe that lupus is a disease of females, it's going to be much harder to diagnose it in males. Renal disease, again, you can see this huge range from in the high 30s to low 40s in some centers to as high as 71.4%. This again may reflect referrals, who's reporting it, and again, awareness of the disease. If you think again, renal disease and lupus, you're going to make the diagnosis of it. CNS disease really varies by country, and this may have to do with definitions. Similarly, cardiovascular disease may really have to do definitions. If you include serositis in cardiovascular disease, you're going to get a much higher percentage of patients. But if you only say myocarditis rather than pericarditis and valvular heart disease, then your incidence are going to be very low. Skin disease is one of the most common, in some places up to 84%. And I come down to autoantibodies to show again, this actually is probably genetically driven, more ethnically driven, because that we know that autoantibodies, particularly anti-Ro in this case, is present in certain populations, particularly in Asia, whereas anti-SM antibodies are certainly in North America, are more common in people of Afro-Caribbean descent. And as you can see on this slide, on the left-hand side, I'm showing you the ethnicity in our population, where the blue is Caucasian. And at this point, although this is not the 50% I talked about, because this was earlier, you can see that Caucasians are underrepresented relatively. South Asians, people of what in this case, one of a better way to put it, people identify according to Health Canada's way of looking at, Stats Canada way of looking at it, as Black and also Asians. So ethnicity or racial background is certainly important. Not only in the presence of incidents, but also, as you can see, it is also in the clinical manifestations, rashes, etc. And as I said before, autoantibodies definitely are driven. You can see in the red the differences in some autoantibodies of Caucasian versus non-Caucasian. Interestingly, though, when we looked at long-term survival, we did not damage-free survival. We did not look at long-term patient survival, mainly because we luckily have so few deaths while they're being followed at our clinic, that the damage-free survival was almost identical. And this is a study from Brazil, and they looked at 847 patients with childhood onset lupus. And I want to highlight here really only two things. One is that there is a group less than 6 years old. And you can see really they do differ in the red. When you look at the red bars that I highlighted it with, they differ from the other patients, group B and group C, which tend to be more similar to each other. That's important. I'll get back to that. Now, group A, it was a small number, 39 out of the 847, but those patients differ, and many of those we are now recognizing with new genetic testing have what we refer to as monogenic lupus. And they do run a different course and they do look different. So it's important to keep in our minds that maybe those patients should be left out. Interestingly, of course, I did present you with a 4-year-old who was actually the exception to the rule, because we did look at her genes and could not find evidence of monogenic lupus. So what about any difference in outcome when we look at the cutoff? If I go back here, that they really use the same cutoffs of less than 12 years and 12 years. So that's sort of the time of puberty, and many people will look at that as a cutoff or outcome and anything else. And the answer was, as I showed you before, we didn't find any difference in what they looked like. This study from New York really found that there was no difference in the ethnicity, no difference in the percentage or type of renal disease, but there was a higher percentage of patients with early onset who had a pediatric intensive care unit admission. Numbers are small at only 34 in each group. They were well matched. However, that's a very high rate of ICU admissions relative to certainly what we see. And again, some of this has to do with access to healthcare. This hospital happens to be in an area where access to private
Recording stopped.
Access to private insurance is limited. And there's a lot of
Recording in progress.
A lot of late diagnoses. So you can really see that this is the same group, no difference again in the clinical manifestations. I'm just pointing out two things here. And one is MAS, or macrophage activation syndrome. I would have wanted to talk about it. We just really don't have time. And you can see that there were 2 out of 64 patients who had it. This is very important to recognize. It does cause early death in lupus patients and may be underdiagnosed. And similarly, again, TTP, which is much rarer in adults, we see that again. Here we're talking about 3-4% of the patients. So those are important issues, but uncommon, but super important to diagnose because of the possibility of it leading to serious complications and or death. So when we talk about outcome, of course, we talk about patient survival. I show you this importantly. So this is a study out of Columbia, and I bring it up because not a lot of data such as this. Again, small numbers, but we are dealing with childhood onset lupus. And you can see that until 1980, only 2 of 31 patients received cyclophosphamide or any immunosuppressive agent in addition to steroids. They did all receive steroid. So the first change in lupus, of course, was the introduction of prednisone. Then was the second major change was the introduction of a second immunosuppressive agent, cyclophosphamide, azathioprine, and now mycophenolate mofetil. And then the introduction of hydroxychloroquine. And I'll show you the data from this in a minute. The difference between that and those fall from 84 to 2000. Now, all of a sudden, a lot of the patients received cyclophosphamide and or azathioprine. There was more plaquenil use, and the survival of this group of patients was excellent at 95% at 5 years, 90% at 10 years, small numbers, and less if there was renal disease. So I'm going to get to that in this slide here, really showing it more dramatically. If you look at patient survival using a Kaplan-Meier plot, with the left hand showing your presence of patients still alive and months on the x-axis, you can see that almost most patients survived. There were some early deaths. And then if on the earlier cohort, you see some deaths. Of course, the numbers as you come out longer are very small. This dramatically shows the effect of presence of renal disease. When you look on the left side, even, well, I apologize for the 1894, no, it was 1984, my dyslexia comes through again. And you can see in the cohort, the newer cohort, almost everybody lived at their follow-up of up to a mean follow-up of 5 years. And even prior to an immunosuppressive agent, in addition to prednisone, excellent survival in the earlier cohort. The same is not true with renal disease. And they could not comment on CNS disease because they just didn't have enough. The other thing to remember here is there is no effect of hydroxychloroquine can be seen anywhere because it wasn't used. So, as I said, outcomes may vary by country. It's very hard, and a lot of the data I'm going to show you now is going to be on damage, because you can see here on the third bullet that the long-term outcome was excellent. This is 225 patients referred to single center in China. Excellent long-term survival, but interestingly, 10.2% of the patients had damage at baseline, so at their first visit. But that's likely because the time to diagnosis, median time, was more than 2 years. And that's very long by most standards, and we hope by all standards. And again, this is a recognition issue. As you compare that 23 had damage at presentation, however, there was only 9 new damages over time. So treatment will prevent damages, and time and early recognition is crucial to prevent damage. Another country, India, where again one wonders if access there is not the best access to care. In many places, it's a combination of private and public insurance. However, many patients really do not have very good access to care. So despite the cohort is 248 patients, there were 14 deaths. In this survival, infection was a huge cause, including tuberculosis and sepsis. And that reflects access to care the presence of tuberculosis, which is a huge problem if you have lupus, where tuberculosis is endemic, or even in a country like Canada. We had a death at presentation of a patient who presented with lupus, had developed macrophage activation syndrome, recognized very late, and had concomitant tuberculosis because she was born actually in India. The other issue that was on the left-hand side, and then when they looked at this, the predictors of mortality were CNS disease and infection, and I'll get back to that. Another way of looking at survival is flare-free survival, and the right-hand column shows you, unfortunately, most patients will flare, but we know that. So a lot of this will now focus onto damage. As I said, let's go to death for a moment at the bottom of this slide, and you can see why it's going to focus on damage, because death is unusual, luckily, during the pediatric age group. So the 5-year survivals are more than 95%. The 10-year survivals, if you do not follow your patients into adulthood, are difficult to come up with, because a lot of the data I will show you has a survival bias, but I will get to that. What's important in this, let's look at the highlighted ones in red for a moment, rather than going through everything in this busy slide. You can see a huge difference in neuropsychiatric damage. This part of the problem is the interpretation, at least in my opinion, the interpretation of neuropsychiatric damage, which requires 6 months of the changes. We're going to get that in the skin also. So you can see a huge difference from as low as 10% from our clinic to as high as 23% in Turkey. And, you know, it's very difficult if somebody has seizures, as an example, and they're on anti-epileptic, our neurologists will not stop their anti-epileptic medicine for at least 6 months. And for those who know the SLIC ACR damage index, that gives you CNS damage if you've been on it for more than 6 months. And that's what a lot of our damage is from some of it is certainly from anti-epileptic medicine. There are some flaws in what we do, how we measure it. What's really amazing to me is we had 3.1% renal damage, Malaysia, 2.1%. We had one of the shorter mean follow-up or median follow-up times at 42 months. Malaysia, however, had a huge 6.3 months, and they were only 2.1. And other places had it up to 44% and 22%. I really don't understand why it is that different. Similarly, I don't understand how you can get so much pulmonary damage, so much cardiovascular damage so early into the disease, peripheral vascular. And the reason I bring these up is just to show you we're not infallible as physicians in using guidelines. I am positive everybody knows how to read well. The definitions are clearly marked out, but obviously there is a problem in definition just because I don't see how this is possible to get this huge variation. And skin, let me address that right now, because I can address this knowing this. Skin is scarring alopecia for 6 months, not alopecia for 6 months. And I know, speaking to some of the people who did this international study, that some of the patients were reported for alopecia, not scarring alopecia. So as I said, we're not infallible. Similarly, gonadal failure is an adult definition, not one that is applicable to pediatric childhood onset patients, as all pediatricians know that when women develop, when young girls, young adolescents first start their periods, after they reach puberty, it is notoriously irregular. And we know that's number one. Number two, we also know that stress causes women to their significant changes in their menstruation. Even more so if your menstruation is irregular to start with. And I think the best example is what's been well publicized, that Olympic level female athletes sometimes do not menstruate for many months when they're undergoing intensive training. So that is a problem. And the others are really quite rare malignancies, luckily. And again, it's going to probably malignancies are related to the time of follow-up. I bring this slide to emphasize something of what I said. I want to show you that ocular, it's up here, where it varies from 10.9 up to 29%, depending, and we had 19% in our study where our patients routinely, obviously because they're on Plaquenil, see an eye doctor who will pick up an asymptomatic cataract much better than I can. And so I think we're seeing this huge variation that's actually supposed to be 9. That was their fault, not my fault this time, is under 10% or 9% and change for ocular, huge numbers of neuropsychiatric and renal, and their death was low. So again, in a very large cohort, you can ignore the clustering of this. This is just them trying to show how they could cluster damage, which I didn't find particularly helpful clinically, but again, to show that there's this big variation. So is this important? Well, yeah, it is important. Again, this is data from Toronto on almost 300 patients showing important things, that if you had no major organ involvement, you had a very low risk of developing any damage, even as little as asymptomatic cataracts, which as I showed you is approximately 20% of our cohort. However, if you had renal and or CNS, you had significant damage over time. And as I showed you previously from the work in India, that CNS is super important for damage. And that, as one can imagine, it's like renal, is related to the use of immunosuppressive agents, plus steroids. Steroids accounting for the damages of ocular and bone, CNS and renal, with the use of immunosuppressive agents and infection and other damages, plus the disease itself leading to their own damages. So again, it's showing that if you do not have major organ involvement, the chances of long-term significant damage are very low. And as I said, much of the damage, obviously you can't see it here, with no major organ would be related really to ocular from steroids, and many of those were asymptomatic. So this was a study that I showed you before, that large international study that looked at, again, looked at what was associated with damage, and strikingly, again, it was CNS damage. And the more cyclophosphamide you had, the more damage. Not surprisingly, cyclophosphamide being a surrogate for disease severity and or presence of CNS and renal disease at this point. Most people in this study would use cyclophosphamide pulses for both renal and CNS disease. And not surprisingly, again, that disease duration was associated with having some damage, and their cutoff in this particular one was at the bottom for greater than 7.17 years. So again, over time, damage does accrue in very large cohorts. So all the studies I've showed you to date have been pediatric patients followed by pediatricians. Okay. This is now patients who were diagnosed as childhood onset lupus, but followed into adulthood. And this is what I'm going to focus on for the moment. Obviously, this series has very small numbers, 24 patients initially. But the point of this is that over time into adulthood, there is significant increasing numbers of damage, which appears to escalate. The slope appears to escalate over 5 years, where one looks at 50%, 72%, 85%, small numbers, but that the median damage continues to rise. So people who had damage tend to get more damage. Again, nothing surprising, and does tend to mimic studies in adult onset lupus. So what else has been done in pediatric lupus long-term outcome into adulthood? And this is crucial. And this was why we established this clinic I was discussing, where we attempt to see all our graduates long-term into adulthood, and then we can follow them, we hope, for many, many years with the collaboration with our internal medicine colleagues. So this is a study from the Netherlands, which is pretty good, looked at 111 patients, not prospectively followed. The one I showed you from Italy, these patients were prospectively followed. They had a median disease duration of 20 years. Okay, this was done through the Dutch Lupus Association with their collaboration. And the important caveat here is anybody who died was missing. Okay. And it was a very select group, but taking all that into account, what one still sees is over time, the black being damage, the clear part of this histogram being no damage. The y-axis are the number of patients, not percentage, and the x-axis in years. And what you can see, obviously, is pretty obvious that over time, there is increasing damage, with almost all the patients followed 30 years, not a lot, greater than 30 years, 21 patients, but they almost all had some damage, unfortunately. There was no comment directly of the significance of the damage. And as we all know, damage is not damage is not damage. Having a cerebral infarct and a stroke, which remains with damage, is not the same with having a cataract. Even if you need cataract surgery, it's not the same as having a vertebral fracture. If you recover from it, and a vertebral fracture is not the same, despite its scars and bone, as a vascular necrosis requiring joint replacement. So all those issues are huge, and we really have very little data on childhood onset. So what do we have in 2017? Dr. Lim, who is a lupus fellow with us in Toronto, got her PhD looking at modeling, longitudinal modeling of patients into adulthood. We had the collaboration to do this study of our internal medicine colleagues, many of which, well, who Dr. Tulloch Reed and Dr. McGee know well because they helped train them. So I want to make this clear. This was impossible to do without the collaboration of our internal medicine colleagues. At this point, we had 473 patients that we had good longitudinal follow-up of. This is about 85% of all patients who presented to our clinic and we had who qualified for entry into this study. So pretty good follow-up. Only good news, 2% died. And as I said, 14% were lost to follow-up. 65% were 18 years or more. So again, vast majority into adulthood. Median follow-up was 5.6 years, maximum of 26 years. And I want to show you now the bottom, go through this slowly. We use the SLIC ACR damage index, referred to as the SDI. And at 5 years, the mean damage was 0.64. At 10 years, 1.6, then 1.67, 2.16, and at 25 years, 2.64. Again, showing, not surprisingly, but unfortunately, that the damage accrues over time. And to look at the true outcome of childhood onset lupus, see, even I make that mistake, catching myself, it should always be childhood onset. Anyway, very few, there's no pediatric patient by definition who could be followed in a pediatric hospital at age 25. They were -7 when they got their lupus. So not being facetious, we need these collaborative studies. What did we find? Well, in the study, the predictors of damage were Afro-Caribbean. Fortunate, but not surprising. Again, if you remember, and you've got to remember back to an earlier slide, it's about 15 to 20% of our lupus population. Not surprising, the prolonged use of prednisone. So people who use prednisone were still on prednisone at 12 and 24 months had more damage. Again, a lot of the damage is prednisone induced. And next point is that for every 10 milligrams of prednisone increase, it was associated with increased damage. Not surprising. I apologize for us. It was cyclophosphamide used at 6, 12, 18, and 24 months. Again, a surrogate for severe disease. And it really is, as all lupus docs know, hard to measure what severe disease is. Renal disease that has proliferative nephritis, we know that's bad, but how do we know that some of those go into remission and do well, and some of them do badly? So cyclophosphamide use, particularly in Toronto, where we tend not to use cyclophosphamide for renal disease routinely, its use reflects bad failed renal disease and or CNS disease, because we tend to use that for CNS disease. So we have to put everything into the context, as we said before, of the clinic and the country when we're looking at outcome. We were able to show that antimalarial use was protective. This really is the first pediatric study to show it's known in the adult literature. And again, those diagnosed in the 2000s did accrue less damage than those in the 1980s. Again, over the same period, length of time, it was not a follow-up issue. This really, again, reflects the routine use and, I believe, better use of immunosuppressive agents. But really, it does not reflect or comment at all on whether the use of azathioprine or MMF is superior in the long term in renal disease, because we do not have in this study, where the data actually ended in 2010, because how long it takes to get all the data and get your PhD, blah, 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 and publish. We had no long-term data out 10 years on patients with MMF. We shall see if this does improve the long-term outcome and whether the use of biologics will improve the long-term outcome. So what did also Dr. Lim found? She found that this is very interesting, looking at what's called latent class analysis, that she could find 5 types of disease. I'm going to take you across the top. There was what was called relapsing disease transforming. So what that means is that you had mild disease early on, and then you got bad disease. I'm going to pick this up because I just looked at the time. You had early onset disease, and then remission, low grade, moderate. And really the point of the story when you come into the low grade activity was that these patients did what better. And it was, interestingly, ethnically driven. Again, not surprising. And this is just showing you what I showed, that the class 1, not surprisingly, did the worst. That's the high disease activity. And the ones who had low-grade disease didn't do so well. I did very well. So what I'm going to do is I'm actually going to skip all these slides for a moment and just go right to, actually, I'm going to come back for 2 seconds to look at something very, very important. What we've looked at so far are disease, survival, and damage. But what about disability? Okay, unimportant this slide, but this is the importance of patient-measured outcomes. We can't forget, especially in lupus, that what we think is good control may or may not reflect the patient. So disability as measured by the child HAC, or which is a very similar show, most patients had very little disability. Pain, however, was much more distributed. And of course, pain is so important. And interestingly, I don't know why these move, what did they find was associated with disability and its outcome, its household income. Patients with the lowest income had more disability. The use of cyclophosphamide was unrelated. Arthritis was important for disability, not surprised, as was pain. So we just can't forget what we think is important, which I talked about up to this point, and what is important from the patients. So I will conclude now. I hope the messages you'll walk away with is that the long-term outcome has improved with the use of other immunosuppressant agents in addition to steroids. 5-year patient survival is excellent. We don't have a lot of data on 10 and 20 year. Ethnicity may play a role in damage accrual and long-term survival. Damage accrual is related to persistent and or long-term disease activity and the presence of CNS and renal. And if you have both, it is actually more likely to get more damage. Hydroxychloroquine use was associated with less damage accrual. There really is limited data into adulthood, and almost all studies have survivor bias where only survivors are being contacted long-term. True patient-measured outcomes are not well studied, and that comes back to the point number 4. Patient adherence is important, but not well studied. If you're feeling well and doing well, you may not be as wanting of a drug you hate, and I use that word for sure, such as prednisone, whereas if you have a lot of disability and pain, you might. We need new therapies to decrease damage. And I believe that childhood onset lupus is still underdiagnosed. And I want to thank you. And I want to thank you for inviting me to talk about something. As you can hear, I could go on for hours. Thank you. Okay, let me stop the share screen. All right, let me get out of here. Okay, I'll go back to the.
Thank you so much. Thank you so much,
Yeah.
Silverman. We thank you very much for a comprehensive talk on the outcomes in childhood onset lupus. Thank you so much. We are definitely encouraged by the understanding that in the past 2 decades, we are seeing less damage accrual and improved survival. And our symposium is always well attended by many patients. And so we just want to hang on to that as one of the key messages from your talk. We thank you very much for sharing your years of experience and insight in this matter. We're going to open for questions. We do have a few questions already sent in, and we just invite you. No question is, out of bounds. Just this is a great opportunity to have a world expert answer your questions, patients, colleagues. So send your questions in. We look forward to having them answered by Professor Silverman. Professor Silverman, Dr. John Newman has asked, are we seeing an increase in the incidence of lupus in younger, especially pre-pubertal population in the past decades or so?
I believe strongly, no, it's an increase in recognition. Okay, I think that's, but impossible to prove. Okay, I can just show you and tell you our data over time is that we have increasing numbers of patients pre-pubertal. Okay, and we're going to ignore, as I said, the very young onset. That's a different disease. Under 5, let's ignore that. It's recognition. Everybody knows, quote unquote, children do not get lupus. Everybody knows that. And so if you can't get lupus, how can you diagnose lupus? And maybe a 16-year-old, but not an 8-year-old. They have JAA or reactive arthritis or a viral infection. We're getting increasing referrals early, and it's the awareness. And I hope, we're fortunate in Canada and in Toronto, if you count me still as part of Sick Kids, we have 8 rheumatologists. Canada has, I don't know, maybe 50 now, and a population 35 million. How many pediatric rheumatologists in Jamaica? How many people know lupus exists in Jamaica, where we know the incidence has to be higher? So I think that's the answer to the question.
Just jumping on that question, what presentations do you think that clinicians and parents may miss? What are the presentations that may often be overlooked and thought of as being something else, because we know lupus is the disease of many faces?
So I think what we see, and what again has increased our numbers, is a close association with our hematologists, who now routinely check ANAs on all patients with ITP. Okay, and it really has increased our referrals. So if somebody has a positive ANA unrelated to the use of intravenous immunoglobulin, we see them. Okay, that's really, and so you know what? We now see a lot of patients that we follow who don't quite have lupus, but we worry they're going to get it. And so I think that's one important issue. Evans syndrome, hemolytic anemia, thrombocytopenia in childhood is almost always lupus. Patients with clots, again, you have to think of lupus. So I think that's one thing that you have to be aware of. And the other issue is our close relationship with dermatologists. Discoid lupus in childhood, isolated, is very rare. Unlike, again, as Dr. McGee and Dr. Telequid are aware, in adults, isolated discoid lupus occurs. It almost never occurs in pediatrics. Chorea is another thing to think of lupus. So I think those are the things, and that not all inflammatory arthritis persistent in children is JIA. And I think when I was referring to in our clinic, when I used to do general rheumatology, if I saw a dark-skinned person who had female adolescent with polyarthritis, they had lupus, not JIA, until proven otherwise. So I think it's that whole idea of awareness that it exists. So those are the big things. And the other one is psychosis. We still see patients, and I'm sure you do, who are treated for schizophrenia. Now, schizophrenia, again, we know has a significant incidence in adolescents, but also lupus can present with isolated psychosis. There are features, and I'm not going to get into, which can help you differentiate, but it's awareness. A screening ANA is so easy. And again, our psychiatric colleagues have increased their awareness, as ours of our adolescent medicine colleagues. So I think that's basically it. Renal is the easiest, honestly, because you see a nephrologist and they know what to do.
Professor Silverman, Nicole Solomon is asking, aside from monogenetic lupus, are we understanding more about the ethnic difference for onset of childhood onset lupus?
Okay, so Dr. Linda Hiraki, who has joined us in the last 5 years as a genetic epidemiologist, this is what she's spending her life doing. The answer is yes. All genetic studies, not only in childhood onset, but adult onset, well recognize that our genes are driven by our genetic background. So we recognize that there are different susceptibilities in different genetic backgrounds, but we haven't quite gotten to why, as an adult, it is about, the incidence is about double in people who are not Caucasian. We haven't quite identified those genes yet, but we do know that you have to take them into account when you're looking at it. So no, we're not there yet. And monogenic lupus per se does not does have obvious ethnicity background, but that's more related to small communities and inbreeding, and really is related to that much more than where you were born per se.
So Professor Silverman, that question was from your pediatric colleague, Dr. Nicole Johnson.
Yeah, of course, I saw her there.
So we have another Nicole. Nicole Solomon is with us, and she's asking, when would you recommend plasmapheresis? And perhaps for those who don't quite understand plasmapheresis, you could start by explaining that for us.
Okay, so plasmapheresis is where you hook someone up and you remove certain parts of their bloodstream, where you remove, in this particular case, you remove the antibodies present in the belief that the circulating antibodies, if I can get them out, I will decrease the disease activity. That's it in a nutshell. It is a quite invasive procedure, requires sophisticated equipment, but having said all that, in the right hand, it's a pretty safe procedure. So the answer is almost never. I think I can't remember for lupus the last time I recommended it. That's the answer. The studies have shown that the long-term outcome is no better. In childhood, it is really, oh, there was one, and I misspoke. TTP. If you have TTP and lupus, plasmapheresis helps, because we know that plasmapheresis helps in TTP. So it is the treatment of choice, in fact, for TTP secondary to lupus as it is for primary TTP. But that's the only time I can remember in the last 10 years, 20 years, or longer, that we've used plasmapheresis. So that is the one indication that we've used it for. The problem is, let me just finish, sorry. It's very immunosuppressive. And if you use it in the presence of other immunosuppressants, you do run the risk of serious life-threatening infection.
Thank you, Prof. One of the contributing factors to poor outcomes is adherence, so non-compliance with medications. Can you share with us any sort of institutionally implemented strategies that you have that we as clinicians can adopt?
Prayer, how's that? No, in all seriousness, I don't know what to do. The first thing I try to do, though, is try to say honesty. Okay. And I've tried lots of things over the years. And at the end of the day, what I try to tell my patients is, yes, you hate prednisone. I hate prednisone. I know everything you can imagine, or you've seen. I've seen it way more. And unfortunately, I say it's your best friend and your worst enemy. And the reason I come back to honesty is because it changes so much in what we're going to do. If somebody truly is non-adherent to what we suggest, then if they flare, it doesn't mean there is a failure of the medication, whether it be prednisone or anything else. However, if you flare, let's say with renal disease, and you're on azathioprine, mycophenolate mofetil, and you're taking it faithfully, and you're really taking it, then that's very different from the person who doesn't take it. Beyond that, I wish I knew. The other thing is keeping your fingers crossed. And hoping that they finally reach the age when they realize they're not invincible, which probably isn't until the mid-20s, unfortunately. I will tell you something, like a joke I tell everybody. Everybody knows that they have a sweet child who listens to them, but when they become an adolescent, they get abducted by the aliens. The aliens eventually return your sweet child who listens to you somewhere between 20 and 30. And the same thing holds here, only this is the invincibleness. So sometimes they do come back. We've tried things like taking to a dialysis unit, but you know what? That really doesn't help very much. It really doesn't, because it's not going to happen to them. We take them, we've tried that. I'm not convinced that helps. We have somebody else say the same thing to them. We've tried peer, maybe peer, but it's really hard to get that. So I wish I knew the answer, but there isn't a great one.
Well, thank you. Shared. You've given us some things to think about. So thank you for that. We have a question from Professor Marshall Toller-Reed. He is our epidemiologist here in Jamaica. What are the considerations regarding growth and reproductive health when choosing lupus therapy in this age group?
Okay, excellent question. I didn't get at growth. Now, growth is huge. Now, here's where there's a huge difference between pre-pubertal and post-pubertal patients. So I didn't talk about that just because there wasn't time. We recently showed that if your lupus is diagnosed somewhere after puberty, really your amount of growth is very limited. You really don't. Your epiphyses are pretty well closed, and maybe there's a few centimeters left in growth. However, if you're 8 years old, it's huge. And significant growth, we found significant growth failure related to the amount of steroids used. Not surprisingly, well, we knew this. How we get around it, we don't know. To my knowledge, there is no drug that differentiates the steroid from the growth failure effect, from the osteoporosis effect, from the avascular necrosis effect. So that's the first thing. One. The second issue is younger patients tend to need more steroid for the same effect. It's very individualized, but yes, it's super important, but I don't know a way around it, unfortunately, because if you don't use them for renal disease, your chance of not going into end-stage renal disease is high. Is very high if you have proliferative lupus nephritis. If you have CNS disease, your chance of having a good outcome is very low. So that's that. We do early in all patients who go on high-dose steroids, we immediately start a second-line agent, such as usually mycophenolate mofetil. In the past, it was azathioprine. We tend, which is getting to the second part of the question, we do not routinely use intravenous cyclophosphamide. We almost never, I can't remember the last time I used oral cyclophosphamide. No, probably in the 80s for lupus. So that's the answer of how we attempt to avoid gonadal toxicity and reproduction issues. The good news about that is the data looks pretty good for even the use of cyclophosphamide and gonadal outcome. It's not the same giving cyclophosphamide to a perimenopausal woman and the chance of inducing early menopause as giving it to a 14-year-old. The data we rely on, honestly, comes from the oncology literature, and it actually looks pretty good. We do restrict the amount of cyclophosphamide we use. We do use for renal disease, the so-called urolupus, where you only get 3 grams of cyclophosphamide. And we know the gonadal toxicity as well as the oncogenicity is cumulative dose related. We do not routinely harvest eggs. We do not routinely use Luperon to alter to protect the gonads. And that probably reflects the fact that we don't use cyclophosphamide that much. I know some people advocate it. And there's no downside to harvesting eggs. I don't see a downside. If you have that facility, I'm not sure Luperon helps.
Thank you so much, Professor Silverman. I'd just like to remind our participants that they can actually type questions in the chat. We are going to take a question from one of our participants, Dawn McNaughton. Says, could you elaborate a bit on what is particularly important about looking at the ear in pediatric patients? An interesting question, the ear.
I wish I knew. People have looked into it. I'm sure there's something. I just don't know what. The air has to. We're coming back to the idea that the environment must play a role. Mm-hmm. Unfortunately, we do not know what that is. I mean, so I wish I knew the answer, but it's got to. I just can't see how the presence of carcinogens, the presence of all these toxic things we bring in cannot alter our immune system. But how? I don't know.
Okay. Prof, I think she meant EAR, so actual ear as in our ear.
Oh,
hearing.
I'm sorry. I'm sorry. My ear isn't so. I'm getting old. I apologize. I'm not sure what the question is. And is there problem? Right. Oh, I know what I understand the question. Yeah. So the idea, what I was just trying to get at with the ear was that it's a great place to look for skin disease. And that was one of the things I was taught by dermatologists, because, sometimes it can be hard to differentiate sunburn from a malar rash. There is some nasolabial sparing with sunburn, maybe not as much. But the ear, you rarely get sunburned ears. So that's why it can be helpful for that reason. And it really has been at times. So I think that's why it's always good to know. It comes back to really nothing replaces a good physical exam. And unfortunately, in the age of COVID-19, we're not doing it as much as we used to. But a good physical, thorough examination, anybody looking for lupus, you look everywhere in the skin, everywhere, even up their nose. I look, and so it's everywhere, but the ear is particularly good for that reason.
Thank you, Prof. There is a question from an anonymous attendee. What's a typical or average duration of steroid therapy in children with lupus? And is it that persons with renal disease always need to be on steroids?
Good question. And the answer is no for all renal disease. Okay. Renal, and I don't want to take the thunder out of the renal talk, but there are, they talk about 5 types of renal disease, but we'll ignore type 1. The proliferative renal disease, class 3 and 4, yes, requires steroids. Class 2 and 5 may not, and class 1 is basically normal, so we're going to ignore that. So the answer is there is no routine use. We, in fact, though, I used to be pretty dogmatic about how you treated proliferative lupus nephritis. So the worst type, class 3 and 4. And it was a very fixed regimen. In my old age, I realized that there's got to be a difference, and my wife's a nephrologist, so that might help. There's got to be a difference patient who comes in with an elevated creatinine, hypertensive, and spilling 5 grams of protein a day, and their biopsy shows class 4 lupus nephritis. And somebody who comes in who happens to get a urinalysis and had blood and protein, but is feeling well, they're spilling 5 101 milligram of protein. I made that because that's sort of the cutoff people use in saying, are you in remission or not? Normal creatinine, normal blood pressure, and still the serology is high. They both have lots of anti-DNA antibodies and low complement and lot. Their biopsy shows you couldn't tell the difference between the two. They can't be quite the same. I used to treat them the same. I really did, because of the fear and my feeling of, was it worth over treating patients rather than under treating? So how many patients you have to over treat, so-called over treat to undertreat. Now I realize over time that, you know what, those patients did really well. If we used a second line agent, such as, and now it is MMF routinely in Toronto, just because we can afford it. If you can't, I'm a great advocate of azathioprine, that they don't need the same treatment. They may not need as much prednisone to start, and certainly not as long treatment. So the answer is, I could have given you a nice thing for proliferative lupus nephritis, and now I modify that depending on the patient. And I think that's the way to go to prevent the side effects that we know occur because of prednisone. And, you know, the data shows it. The data I showed you is that a lot of the data is steroid side effects. The bone's all steroids.
Thank you so much, Professor Silverman. Unfortunately, we have to end our question and answer segment for this keynote presentation. We could go on and on, I'm sure. And I just want to echo the sentiments that have been expressed by many of our attendees in the chat, lauding the presentation as excellent, comprehensive, and a wealth of information shared so concisely. We thank you for your time and your expertise. Thank you, sir.
It was my pleasure, and I really want to thank you for inviting me. And Toronto really doesn't look like that today. That was last year in the winter from my son's cabin in the Laurentians.
Okay, great. It's warm here in Jamaica, so hopefully in the future you'll be here with us.
I hope so.
For another symposium. We thank our attendees also for participating by sending in your questions, and thank you so much for joining us. Just to remind you that you can continue to post your questions in the chat, and we will try to ask presenters to address them during the course of the meeting if they are able. And so we thank you for being with us for the first segment of our symposium. And we're going to now go to the title sponsor for the symposium, the National Health Fund, as we segue into our nephrology segment. Thank you so much for being with us. And it's been my pleasure being your moderator. Thank you.
Thank you very much, Dr. Tanisha McGee Phillips. I truly have been as rewarded by the presentation by Professor Earl Silverman on the outcomes on childhood onset of lupus. It was a section that I thought everybody would have been truly benefited from, because his wealth of experience and wealth of knowledge in this area certainly shone through. The number of questions that I saw coming in, I'm just unfortunate we couldn't accommodate all the questions, but certainly the wealth of information he shared. Professor Earl Silverman, we thank you very much. And I think that there was a lot learned. And again, of course, I'd like to thank Dr. Tanisha McGee Phillips, who most ably moderated that session. We look forward to the sessions that are coming up. But right now, as I did promise you before, we have a musical piece. And in fact, we have two musical pieces, one by Holly Thomas, which is My Garden, and also followed very quickly by Sebastian Gordon, who will be providing a piece called Fiesta. And both students are piano students of the Music House. So please join me welcoming at this stage, though virtually, Holly Thomas as she presents My Garden, followed by Sebastian Gordon with Fiesta. Please enjoy.
Hi, my name is Holly. Lupus can affect children too, and they need your support. Join the fight.
My name is Sebastian. Although the average age for lupus in children is around age 12, younger children can be affected too. They need your help to bring an end to this cruel disease. Join the fight.
Thank you very much. That was from Holly Thomas and Sebastian Gordon. Both pieces, My Garden and The Fiesta. I'd like to thank them very much. Two extremely young and talented individuals who I'm sure we will be hearing more from in definitely the future. So definitely keep your eyes open on that space. Thank you very much again. Definitely, we'd like to thank you once again for joining us for today, our annual symposium put on by the Lupus Foundation of Jamaica under the theme Children and Youth with Lupus, Improving Outcomes Through Knowledge and Support. Of course, today's event features local and international speakers, placing the spotlight on improving treatment and support for this vulnerable group. I'd like to take this opportunity to encourage our viewers on YouTube and Facebook as well. If you have those burning questions, please feel free to go to our website and register at www.lupusfoundationofjamaica.org. Right, so go there, register, and ensure that you get your information in as quickly as possible. And of course, please follow us on our social media pages on Facebook, YouTube, and Instagram. And of course, we can also be located at, well, certainly Physical Educational Center at 7 Barbados Avenue. That's in New Kingston, Kingston 5. And we can be reached at 876-754-8458. And our helpline is 876-778-3892. Once more, 754-8458 or 876-778-8392. And of course, our website, as we just said, is at www.lupusfoundationofjamaica.org. Just like to give a quick shout out and definitely thank you to our title sponsors. And our title sponsor is the National Health Fund, definitely providing health support and logistics. And we are truly indebted to them and really a great organization. Our gold sponsor today is IPCA Laboratories. And I would like to thank them again for their tremendous support and for being with us again this year. And of course, we would like to thank as well our silver sponsors with Cinco, Dr. Reddy's, and CariMed. So Thank you very much. We hope that you continue to support us, and of course the Jamaican public and persons across the world. Feel free to support them. These are really wonderful organizations that have been doing a wealth of good in Jamaica at this time. So that is it. So that is www.lupusfoundationofjamaica.org to make sure that you register and get everything in place online, so that you are not left out, and that information that you can send in. So we have in store for you a number of other great sessions. I'd like to describe the next session as the nephrology session, but certainly for those of us who are not as inclined with some of these terminologies, this session speaks to the kidney in pediatric lupus. Session 3, just to let you know, so that you never miss a beat, we will be dealing with appearance and adherence. Of course, Dr. Raquel Jones will be moderating that session. Session 4, adolescence and lupus, with Dr. Karel Decula. And of course, in session 5, we'll be looking, just as importantly, at making the difference in child adolescent with lupus. So our next session, the nephrology section, speaks to the kidney in pediatric lupus. You definitely don't want to miss that. And of course, we will be introducing our moderator very shortly for that. That is Dr. Laurie Ann Fisher, consultant nephrologist at the University Hospital of the West Indies. Very accomplished doctor as well, so you want to stay tuned for this. In fact, almost all these sections, you don't want to miss. So let us now move to the section 2, which is the kidney in pediatric lupus, and we welcome Dr. Laurie Ann Fisher and Dr. Laurie Ann Fisher, the consultant in nephrology, as we now embark on this section. Dr. Fisher.
Hi, good afternoon, everyone. It is my pleasure to moderate this session, which is kind of dear to my heart. Today we're going to be talking about the kidney in pediatric lupus, and as our presenters have mentioned before, the kidney renal disease in pediatric lupus confers a worsened prognosis, and it's important to recognize and treat this condition. So I'm going to now welcome my first speaker. Her name is Dr. Rebecca Thomas Chen. She is a pediatric nephrologist and associate lecturer at the University Hospital of the West Indies. Rebecca actually went to medical school at the University of the West Indies, did her undergraduate there and her postgraduates in pediatrics. And in her pediatrics, gravitated towards nephrology, prompting a fellowship at McGill University in Montreal, Canada, where she did pediatric nephrology. At that time, kind of gaining her expertise. Returning to Jamaica, she's now a practicing nephrologist at the University of the West Indies. She is now currently pursuing her master's in epidemiology at University of the West Indies. And her research interests and interests in general are just improving outcomes in pediatric nephrology. And I'm really happy to introduce our speaker, very accomplished Dr. Thomas Chen.
Thank you. Thank you so much, Laurie. I'm just going to go ahead and share my slide. Okay, are you able to see that?
Yes, we are very well.
Great, thank you. All right, so hi everyone, and thanks for listening in. I'll be speaking about the clinical pathological features of lupus nephritis in children. So essentially, we've gotten a bit of this data before, but SLE presenting in childhood accounts for, on average, 15 to 20% of cases worldwide. Renal disease occurs in a wide variation, but between 50 to 75% of all pediatric SLE. And of those children, more than 90% will go on to develop lupus nephritis within the first 2 years of their diagnosis. The age groups that are preferentially involved are those between ages 10 to 13 years, and the incidence is generally about 0.72 per 100,000 per year. Significant for our population, the incidence of lupus nephritis is higher in Blacks, as well as Hispanics and Asian patients with SLE when compared to whites, which is going to be relevant for our ethnic derivation here in the Caribbean. The general presenting signs are really sort of non-specific. They result from alterations of kidney function. And so they include proteinuria, edema, which is due to progressive fluid accumulation, decreased urine outputs, growth or microscopic hematuria, and hypertension. It's important to note, though, that a significant percentage may be asymptomatic, and so you really may just pick this up because you've done additional testing, but not because of signs or symptoms that you notice on examination or from history. So in addition to a good history, great physical examination, things that you would focus on would be blood pressure monitoring, as well as urinalysis and microscopy. In pediatrics, and I will say definitely here, but you know, I think it goes for overseas as well, that the 24-hour timed collections that the adults are very good at getting probably is not so easy to get in children. You know, you tend to get missed urine samples that were lost, somebody wet the bed, or with a different caregiver, they forgot. And so in order to get a good quantification of the proteinuria, it's safer to do a spot urine protein to creatinine ratio, where you just take a single sample, generally the first morning sample, to rule out the orthostatic proteinuria effect. And you send that to the lab, they test the protein and the creatinine, and then they give you a ratio, and that correlates really well with what the 24-hour amount of protein would have been in the urine. But the gold standard remains having a renal biopsy. So when should we biopsy? So you should biopsy patients with lupus who have abnormal proteinuria, which is generally more than 0.5 grams for the day, or 0.5 on the spot urine protein to creatinine ratio. Those who have an active urine sediment, such as persistent hematuria, especially if those are dysmorphic red cells, as well as cellular cast. If it is that the creatinine is rising or there's a decreased GFR, should also move towards biopsy. And though you may have biopsied a patient in the past, if it is that there is newly active sediment in a patient who previously had quiescent disease, or if there are new elevations in serum creatinine or worsening of proteinuria despite treatment, repeat biopsies are suggested as indicated. So the histopathologic classification is based on the International Society of Nephrology and a Renal Pathology Society classification, which had been developed by a group of kidney pathologists, nephrologists, and rheumatologists in 2004 and revised in 2018. It divides SLE-associated glomerular disorders into 6 classes based on kidney biopsy histopathology, and there is the inclusion in that of activity and chronicity indices. So that's just showing a quick pictorial representation of the 6 classes, but we'll go on to discuss them just a little since we're here. We have limited time, so we'll go relatively rapidly. So class 1 is minimal mesangial lupus nephritis. It is the earliest and the mildest form of glomerular involvement. And so patients typically have a normal urinalysis, no proteinuria or just minimal, and they tend to have normal renal function. A biopsy is rarely performed because they look so well, both them as well as their lab parameters. But if it were to be performed, what generally is shown is normal light microscopy and then mesangial immune deposits on immunofluorescence or electron microscopy. Class 2 is mesangial proliferative lupus nephritis, which manifests with microscopic hematuria and or proteinuria. Rarely there is hypertension, and generally they have normal urea and electrolyte panel. They don't have any evidence of nephrosis, which is just significant protein in the urine to the point of nephrotic syndrome. On light microscopy, there tends to be mesangial hypercellularity of any degree or mesangial matrix expansion, whereas on immunofluorescence and electron microscopy, there are a few isolated subepithelial or subendothelial deposits. The renal prognosis is usually excellent. Those who have class 3, it's focal lupus nephritis. And so the patients tend to present with hematuria and proteinuria, some amount of hypertension, a decreased glomerular filtration rate, and/or nephrotic syndrome. Light microscopy shows, just in summary, usually less than 50% of glomeruli having active or inactive undercapillary or extracapillary disease, and usually of each glomerulus, less than 50% is affected. Class 4 lupus nephritis is diffuse lupus nephritis. It is the most common, which is particularly devastating because it's the most severe form of lupus nephritis that we generally see. The patients tend to have hematuria and proteinuria, meeting generally the criteria for nephrotic syndrome, hypertension, as well as reduced glomerular filtration rate. On light microscopy, there is undercapillary with or without extracapillary glomerulonephritis in more than 50% of glomeruli, and this may include hypercellular necrotizing lesions and crescent formation. On electron microscopy, subendothelial deposits are seen. Class 5 is membranous lupus nephritis, and patients tend to present with nephrotic syndrome, plus or minus microscopic hematuria and hypertension. Of note, you could present with lupus, and this is the only manifestation, just the nephrotic syndrome, microscopic hematuria, hypertension, but without the additional systemic manifestations, and it is really only found when the biopsy is done. On light microscopy, what is seen is diffuse thickening of the glomerular capillary wall, and on immunofluorescence or electron microscopy, subepithelial immune deposits. And then class 6 is the advanced sclerosing lupus nephritis. It is a slowly progressive kidney dysfunction in association with proteinuria and a relatively bland urine sediment. But if you do the biopsy, what you tend to see is global sclerosis of more than 90% of glomeruli, which represents healing of prior inflammatory injury. So this is just some pictorial representation of some of the things that I mentioned that can be seen. Now, on immunofluorescence, generally what is described in lupus nephritis is a full house staining where almost everything, all the classes of immunoglobulins as well as C3, C1q, lambda, kappa show significant positive staining. So let's talk a little about what lupus has looked like in Jamaica. So the majority of the data that we have really has been in adults. It hasn't really been much published in children. And perhaps that's because we have a relatively younger, I would say, pediatric nephrology service when compared to perhaps adult nephrology service in the country. However, what we do have is that in 1979, there was a prevalence of about 5 to 17 per 100,000. In 2012, Shriba et al. Published data that was representing what was collected from the lupus registry of 2008, where there were 107 patients. The vast majority were female, as Prof. Silverman had expressed that usually it's a female predominant disease. And there were complications present in 42% of the SLE population. 37% had proteinuria above 0.5 grams per day or active urinary sediments. And so because of this, percutaneous kidney biopsy was performed in about half. And I'm sure that it was performed in half, not because there wasn't a plan to do it in all, but at our sense, so there is a cost factor which is significant, as well as just acceptance by the parents and the patients and their parents of having the biopsy done. Sorry, not patients and their parents, of the patients, because this would have been adults. However, what was found to be the most common histological subtype in 37% was membranous lupus nephritis, which is class 5. Moving on to 2007, Williams et al. Looked at 66 patients who had lupus nephritis. And what they found overall was that those who had proliferative lupus nephritis, which was class 3 or 4, tended to have higher creatinine, higher degrees of hypertension, and higher chronicity scores than other classes. And unfortunately, a quarter of the patients developed end-stage renal disease or died, which is a pretty significant percentage, if you ask me. In 2017, Maloney et al. Looked at 150 patients, which were mostly female. They found that the average age at onset was 33 years. Of those who had biopsy-proven lupus nephritis, it was in 28% of their subjects, and 16.7% met the SLIC diagnostic criteria with only positive antinuclear antibodies or double-stranded DNA antibodies and lupus nephritis on renal biopsy. So of that number, 3 patients had end-stage renal disease, 8 patients had eGFRs, which were less than 50, and 8 patients had nephrotic range proteinuria. Now, this table they compiled as well, which looked at compared the demographic, clinical, and laboratory features of SLE patients of different ethnicities in the Caribbean and in the USA. So the first, I would say, 5 columns or 4 columns are reflecting Jamaica, Curacao, Barbados, and Martinique, which are mostly Afro-Caribbean populations. And then they compare that with separate groups of African Americans in the USA versus Caucasians. Across the board, you could see that females were more disproportionately affected when compared to males. And I'll jump a little bit on just to say that for renal disease, it certainly was more prevalent in anything to do with whether Afro-Caribbean or Afro-American population. There were higher percentages of those having lupus nephritis when compared to the Caucasian population that was studied. And that was significant. So, what is the current picture, and do we have any information at all on our children? So our moderator, who is Dr. Fisher, as well as the nephropathologist, Dr. Bromfield, and myself, did a retrospective chart review of all patients undergoing native kidney biopsies between January 1, 2013 to December 31, 2018. I want to point out here that not all patients who have lupus and who have evidence that would indicate that they should get a biopsy do get a biopsy, and a lot of that is, costing and then also consent from the parents. But there probably is a larger subgroup of patients who would have had presumptive treatment based on what they looked like clinically versus what they would have had on biopsy. We don't know that to this moment. However, this retrospective chart review was of those who actually had biopsies done. So pathology reports were reviewed using the records available at the Department of Pathology at the University Hospital of the West Indies, Mona campus. De-identified data was extracted, including patient demographics, clinical diagnosis, and pathologic features to predict outcome, including the ISN RPS 2003 classification of lupus nephritis. Outcome data included the need for renal replacement therapy, their creatinine levels, the therapies and treatment modalities used, and those were all documented. So in total, we had 50 biopsies done on adults and children with lupus nephritis at this center. Of these, 7 were pediatric patients, which was defined as age less than 18 years. So all were female. Just under 30% had an eGFR of less than 60 mils per meter squared at the time of kidney biopsy. The mean creatinine was 95.6 plus or minus 92.9 micromoles per liter, and the mean body mass index was 21.6 plus or minus 6.4. So we've just extracted, this is pretty rudimentary data, and I've just extracted, because of the time restrictions, some of the things that were found in that in this study. So of the children that were reviewed, all of them had arthritis and photosensitivity meeting the relevant criteria for diagnosis. The malar rash and discoid rash percentages were actually the same, which is interesting because the discoid rash tends to be less common in children generally worldwide. However, serositis was again in just under 1/3 of patients. Less commonly were oral ulcers and seizures, and we really didn't have any of the manifestations documented in these patients who got biopsied of thrombocytopenia and lymphopenia at the time of their presentation. So what were the serological characteristics? So all patients had ANA positivity and anti-double-stranded DNA positivity. I would say a majority, 57.2% and 85.7% respectively, had low complement levels of C3 and C4. The anti-Smith and lupus anticoagulants, there were only one patient each that ended up having positive antibodies there. Now, it's important to note that although autoantibodies are required in the diagnosis of systemic lupus erythematosus, their role in monitoring lupus nephritis is really quite unclear. It's important to do it to make the diagnosis of lupus, but perhaps data will come out later on that will tell us how these can help us better. So the clinical characteristics that we found were that in increasing order, the least common presentation was nephrotic syndrome, and that was in 1 patient. Acute kidney injury was found in 3 patients. There was hematuria and proteinuria in over 80% of patients, and hypertension was found in all patients. The characteristics that were seen on biopsy, I will say probably what was most relevant out of the table was that the WHO class 3 or class 4 classification of lupus nephritis was the most common in terms of what we found as the pathological subtype, with over 70% of patients having class 3 or class 4 lupus nephritis. And then 54% had class 5 lupus nephritis. So in some patients, there coexisted both. Cellular crescents were seen in over 50% of patients, and then between mild to moderate interstitial fibrosis and tubular atrophy was seen in about 45 to 55% of patients. Because the next talk is going on to speak more so about therapies, I thought I'd just include a slide to say what were the induction and maintenance therapies that we had. And so I will say that pretty much all of our patients had a highly steroid-based treatment plan involving either intravenous methylprednisolone or prednisone orally for both induction and maintenance. Induction was, I would say, pretty, evenly split between MMF and cyclophosphamide. So we do tend to use cyclophosphamide quite a lot out here. We try to stay within the upper limits of, what is recommended before, it goes on to provide significant gonadal dysfunction. However, it is based on availability and costing as well, why these choices are made, but it is quite effective in the patients that it has been used in. For maintenance therapies, again, heavily prednisone based. However, MMF and azathioprine were also used to significant percentages for those 7 patients that we saw. For the outcomes, as Prof. Silverman had said, the deaths in terms of pediatric patients are probably not as high, which is really great. We did have 1 patient who had need for renal replacement therapy and went on to have end-stage kidney disease. So that accounted for 14% of the total study population. So in summary, lupus nephritis is a significant concern in childhood SLE. And because of our ethnic origins in Jamaica and in the Caribbean, it does suggest that we will continue to have an at-risk population for lupus nephritis. Of those with lupus nephritis, based on what we got at our center, similar to worldwide data, class 3, 4, and 5 lupus nephritis seem to be the most common, but further work is needed, and it needs to expand to broader centers in the country in order for us to be able to get more information to help to guide our management. These are some of my references, and I thank you very much for your attention.
Thank you, Rebecca, for that presentation. Sorry, Dr. Thomas Chen for that presentation. I think what I'm going to do is, just for the interest of time, is I'm going to do the question and answer at the end of the set. So please, if you have questions for Dr. Thomas Chen, please put them in the chat, and I will try to address them at the end of our session, after Dr. Young-Peart does her presentation. I'd like to again thank our sponsors, National Health Fund, for allowing us to continue with this important conference. And kind of without further ado, I'd like to take this time to introduce our next speaker. Coincidentally, all of the speakers are in the same class, a class of 2007 at University of West Indies. So Sandrika Young-Peart is a pediatric nephrologist and associate lecturer at Bustamante Children's Hospital. She underwent her postgraduate training at the University of the West Indies and earned her DM in pediatrics, where she had her interest in renal disease, and similarly did a fellowship at McGill's University in Montreal, Canada, in pediatric nephrology. There she had her research interests, or she had publications in acute kidney injury, in dengue fever, and also wrote a chapter with one of her mentors on acute kidney injury in pediatric patients. She's an avid volleyball player and wife and mom, and I'm very honored to introduce her today for her talk on updates in management of pediatric lupus nephritis. And with that, I welcome Dr. Young-Peart.
Thank you very much, Dr. Fisher. There is a little problem with my video, so can somebody start my video, please? It's not allowing me to. Okay, thank you very much. Good afternoon, ladies and gentlemen, and it is indeed a pleasure to present this interesting talk at this symposium, the current treatment of lupus nephritis in children. The objectives of the talk are to review the goals of treatment, to review the classification that was nicely done by Dr. Thomas Chen, and the treatment based on the classification, and to review some of the prognostic factors. I'm going to start with two cases, two extreme cases. The first one is case non-ad, who is an adolescent female with systemic lupus erythematosus, and she presents with severe cardiac involvement, acute kidney injury, and other systemic manifestations, and the possibility of query neuroinvolvement. She had a renal biopsy, which revealed class 2 nephritis. Initially, she was treated with prednisone, and subsequently, she received monthly intravenous cyclophosphamide. She improved, but never showed signs of steroid toxicity, despite being on prednisone at high doses for a prolonged period. There's a family history of an aunt who also has SLE, and there was the concern of body image with regards to that particular aunt by the mother. Hydroxychloroquine and mycophenolate mofetil were subsequently added to her regime due to inadequate disease control. The other case is that of case BD. He initially presented at 30 months with prolonged fever and rash, cough and diarrhea, and significant examination findings revealed that he had generalized lymphadenopathy, pallor, and hepatosplenomegaly. He was bicytopenic, and in view of the concern with regards to malignancy, a bone marrow aspirate was done. This was negative. A few months later, he represented with fulminant nephrotic syndrome. He was steroid resistant, and a renal biopsy was done, which showed that he had class 5 lupus nephritis. Significant His urinalysis had 3+ albumin, 4+ blood, and a whopping spot protein to creatinine ratio of 23.5. His ANA was positive, rheumatoid factor was positive, and on echo, he had global pericardial effusion. Now, this may have been said before, but a little bit on pediatric systemic lupus erythematosus, which will be referred subsequently as SLE. It's rare, with an incidence of 0.3 to 0.9 per 100,000 per year, and a prevalence of 3.3 to 24 per 100,000 children. 10 to 20% of all patients with systemic lupus erythematosus are diagnosed during childhood, and so they present with a more severe clinical course compared to adults. There's a higher prevalence of lupus nephritis, hematologic anomalies, photosensitivity, neuropsychiatric issues, and mucocutaneous involvement. So what are the goals of treatment? The goals of treatment are to 1, ensure long-term survival, to achieve the lowest possible disease activity, to prevent organ damage, minimize drug toxicity, improve the quality of life, of course, and to educate patients and their families about their role in disease management. Now, the treatment depends on severity, informal like mild, moderate, or severe. We can take it to more formal approach, looking at the disease activity measurements, utilizing the SLE disease activity index or the SLE response index. Treatment may be organ specific. As well, we also need to treat the complications. So what are some of the treatment options available? Some of them were said earlier. So we have hydroxychloroquine, where we utilize milligrams per kilogram per day, a max of 400 for adults, but for children, max 200 milligrams per day. We can utilize glucocorticoids, utilizing low dose, or we can do high dose, and we can also
maybe some technical difficulties with Dr. Thomas, with Dr. Young-Peart. I think what I will do is, in this time while we kind of sort that out, is try to address one or two of the questions in the chat from Dr. Thomas Chen. There's one question about one, if you think that a lot of the missing data on the cases of lupus nephropathy are due to underdiagnosis or under referral. And Dr. Thomas Chen, can you answer that question?
Okay, so thanks for that question. I do think that it is possible that there are missed cases specifically of lupus nephritis, especially since I said a significant percentage can be asymptomatic. But if you were to perform a biopsy, you would have found something that would have been significant. The issue with paying for the biopsy itself is really quite a challenge. And so I will say that though the N in this reported data here was small, there certainly have been several other patients who have been treated just based on their clinical presentation. And I suppose when in doubt, you kind of are tempted to overtreat to make sure that you don't underdo it and then the patient has progression. But definitely there have been additional patients who have been treated who are outside of this group because they never ended up getting a biopsy for various reasons. But we recently got one pediatric rheumatologist in Jamaica. And so I think, with our relatively newer staffing of pediatric nephrologists, which are now at not just the University Hospital of the West Indies, but also at Bustamante Hospital for Children, and then one in the western end of the island, that we're likely to pick up more as time goes along.
All right, thank you for that answer. There was another one which Dr. Thomas Chen already answered, but just for the benefits of the group, can people change classes of lupus nephritis? And I think Dr. And her answer was yes, switches are not infrequent, especially during flares. So I think Dr. Young Parrott is back, so I'm gonna see if she can start back.
All right, my sincere apologies with regards to that. So I was on the previous slide where we were discussing the different types of therapies available. All right, good. So in terms of your additional therapies, I think we had spoken about glucocorticoids, and the additional therapy would have been NSAIDs that are sometimes used to control musculoskeletal manifestations. We also have immunosuppressives, most of which were mentioned before. So you have your mycophenolate, mofetil, azathioprine, methotrexate, and your calcineurin inhibitors. And we also have a new calcineurin inhibitor on board, vocalosporin, that has good efficacy as well. Regarding nephritis, just want to mention that a lot of the studies were done in adults and very few studies are done in children. With regards to mycophenolate mofetil, it is just as equivalent in terms of efficacy compared to cyclophosphamide. So there were a lot of people who were just with
Yeah, I'm not sure if Dr. Young Parrott is muted. Dr. Young Parrott? Okay, maybe okay, all right. So I think what we're gonna do is just play her recording, just because of her internet connectivity issues. Unfortunately, this is one of the problems of, you know, virtual meetings. I suspect we're going to have to do that. Let me see if I can kind of meet with the technical persons for to play the recording.
Or a max up to 400 milligrams per day for adults, 200 milligrams for the pediatric population. Glucocorticoids, you can utilize low dose or high dose, or you can even do pulse methylprednisolone. NSAIDs are used to control musculoskeletal manifestations, and you have additional immunosuppressives such as your azathioprine, your mycophenolate mofetil, methotrexate, and your calcineurin inhibitors. Mycophenolate mofetil is one of those medications that has been shown to be just as equivalent in terms of efficacy to cyclophosphamide when used as an induction agent, and even more superior to azathioprine for maintenance therapy. Other treatment options available are cyclophosphamide, as I just mentioned, your biologics, your rituximab, and more recently, a newer agent, belimumab, which is a monoclonal antibody that is specific to your B cell stimulators. Dapsone that can be used for your dermatologic manifestations, and you also have your ACE inhibitors, and as well as your bisphosphonates should there be bone disease. Vocalosporin, which is a calcineurin inhibitor, is one of the newer calcineurin inhibitors and has been shown to be just as effective as any of the other immunosuppressives for use during maintenance therapy. The studies with regards to induction are not yet available. Obinutuzumab is also another monoclonal antibody that is available for use. Now, all patients with systemic lupus erythematosus are supposed to be on hydroxychloroquine. The Lumina cohort suggests that there's increased survival, there's a reduced risk of early cumulative damage, there is flare prevention, reduced rash, arthritis, and lipid levels, as well as there are anti-thrombotic effects. Now let's review the classification of lupus nephritis. You have class 1 to 6, with class 1 and 2 being the least severe in terms of presentation. Class 6 is really advanced, so there's probably nothing much that we can do. And then you have class 3, 4, and 5, which necessitate specific treatment. So class 4 is the most severe, but you can also have a combination of 3 and 4, which is also very severe as well. And then you have your class 5. The International Society of Nephrology or Renal Pathology Society 2003 classification system showed that the treatment goal should be complete renal response. Treatment of class 1 should be guided by other symptoms, as well as class 2 should be treated initially with low-dose glucocorticoids, adding only a disease-modifying antirheumatic agent if there is persistent proteinuria or prednisone dependency. Induction of class 3 or 4 should be with mycophenolate mofetil or intravenous cyclophosphamide combined with corticosteroids, and maintenance treatment should be with mycophenolate mofetil or azathioprine for at least 3 years. In pure class 5, mycophenolate mofetil with low-dose prednisone can be used as induction and MMF as maintenance treatment. Now, with regards to the treatment of class 3 and class 4 lupus nephritis, you want to find out if the patient has concomitant thrombotic microangiopathy. If that is the case, then you want to treat the cause of the thrombotic microangiopathy, and then you move on to specific treatment for your lupus nephritis. If they don't have any evidence of thrombotic microangiopathy, then you go towards your treatment, which, as I mentioned earlier, would be with your glucocorticoids combined with your mycophenolate or your cyclophosphamide, or you could do a combination regime with mycophenolate plus your calcineurin inhibitor, or mycophenolate plus the belimumab, or cyclophosphamide plus belimumab. After 6 months, if the patient has not achieved complete response or partial response, then you need to check adherence. If they have, then you want to go to low-dose glucocorticoids plus mycophenolate or azathioprine. If they are non-adherent, then you really want to review adherence, and if they are adherent, then for sure you want to move on to resistant therapy management for lupus nephritis. If they have relapsed in lupus nephritis and they're still stage 3 and 4 without any evidence of class 5 lupus nephritis, then you want to assess the severity of the relapse. Is it mild? And if it is, then you want to assess the timing of the relapse. Did it occur during therapy? If it occurred during therapy, then you want to increase the dose of the glucocorticoids or the dose of the immunosuppressive agent if possible. However, if it occurred after discontinuation of therapy, then you want to restart prior subsequent therapy regime in combination with a short course of glucocorticoids. Now, treatment of pure lupus membranous nephropathy can be with your mycophenolate mofetil plus glucocorticoids as initial therapy, or you can use cyclophosphamide, oral or intravenous. We presently only have intravenous cyclophosphamide available for use here in Jamaica. And you can combine that with your glucocorticoids. Or another option would be your calcineurin inhibitor plus your glucocorticoids. But the studies have shown that utilizing glucocorticoid monotherapy is not very effective at all. And this is really just demonstrating what I say. If you utilize glucocorticoids by itself, the probability of remission is around a little under 30%, whereas with intravenous cyclophosphamide, it goes up to 60%, and with your calcineurin inhibitors, it's closer to 80%. Now, voclosporin, as I mentioned, is one of the newer type of the calcineurin inhibitors, and when they actually compared it with placebo, then they realized that it was just as effective in maintaining remission, and the rate of complete renal response was really good. In terms of refractive disease, you want to increase the dose of the medication or switch to drugs, or you can do a combination therapy. So you could do rituximab with cyclophosphamide, giving you rituximab at 750 milligrams per meter square 2 weeks apart, or you could do rituximab with MMF, or you could do belimumab. If there's a disease flare, then this has to be highly individualized. You can increase the dose of the glucocorticoids followed by mycophenolate mofetil, and you could also do cyclophosphamide. So what are the complications of systemic lupus erythematosus? Well, of course, a big complication is due to the medication toxicity. The glucocorticoids, which can give you myriads of complications from head to toe. And then you have your hydroxychloroquine, of which your ocular complication is one of the more commonest featured. You have infectious complications, where this is due to bacterial, viruses, or fungal. And then you have your macrophage activating syndrome, which usually occurs 1 to 6 months post diagnosis. Now let's look at a little bit at the renal disease prognosis. Now this is actually dependent on the degree of renal involvement. So the greater the degree of renal involvement, the higher the mortality and morbidity of children with SLE. So let's say, for example, class 4. If we look at 10 years and 10 and 19-year mortality rate, that would be around 9 and 12% respectively. And correspondingly, the percentage of end-stage renal disease is 25% at 10 years, and it increases, almost doubling at 19 years. For class 2 and class 3 disease, lupus nephritis, there are no deaths or end-stage renal disease after 24 years of follow-up. And when they compared pure lupus membranous nephropathy, looking at the 10-year renal survival, it was somewhere between 72 to 98%. And patients who were exocytocin 1 and 2 positive, they actually had a better prognosis. So in terms of comparing class 4 with class 5, this showed that the end-stage renal disease rate was higher in class 4 at 43% compared to class 5, which was 14%. Treatment with intravenous cyclophosphamide was also associated with improved quality of life, decreased infections, and hospitalizations. And of course, as you know, in almost all the studies, African American tend have a poor clinical outcome. If they have end-stage renal disease, once you transplant them, they also do very well. Now, this is an older study, but what it shows is that the presence of nephritis actually decreases the percentage survival from closer to 90% to 60%. So in summary, once a patient has systemic lupus erythematosus, a renal biopsy should be considered, as this can help to guide treatment and prognosis. All patients with SLE should be commenced on hydroxychloroquine, and patients with severe lupus should be treated aggressively. Relapsing lupus nephritis can be treated with the initial regime, and medication adherence should be explored in treatment failure. Newer medications are available, which may improve adherence. They were only done in adult studies, but they, as with all diseases, they can be extrapolated to pediatric management. Thank you. Any questions?
So thank you. I've noticed that there is quite a bit of chat talks, questions in the chat, and some were answered thankfully by Prof. And but I'm gonna try and see if I can kind of look through each one of them. Unfortunately, two of our speakers, it looks like one was kicked out of the Zoom, so they're trying to come back in. And Dr. Young Parrott thankfully had given her, unfortunately, due to her internet access, she's unable to answer a few of the questions, but she was willing to give us her email to email us if there is an issue, for you guys to email her questions to us. But let me try to see what other accesses with the group. Let me see. So are there any challenges with access to medications for treatment in Jamaica? Are some of those included in the NHF lupus subsidy? I guess we could ask Dr. Thomas Chen if you're able to answer that question. If not, I may be helpful to answer as well.
I'm here, Lori.
Oh, you're here. Oh, I can't see you. I didn't see you. I'm sorry. Okay, that would be Dr. Young Parrott. Okay.
Okay, so with regards to the medications, because I'm in the public system, the NHF provides access to, we have intravenous cyclophosphamide. We also have mycophenolate mofetil available. Everybody has access to glucocorticoids. In terms of the calcineurin inhibitors, we do have cyclosporine and on special request, some tacrolimus. In terms of the additional medications, rituximab is available at special request. As everybody knows, it costs probably $1 million or close to that. So it is available at special request. So we do have some medications available thanks to NHF facilitating our request for our patients. In terms of the private facilities, it may be a big problem, but we have been working across institutions to try to help our patients as best as possible. I hope that answers the question.
Yeah, thank you. That was a very good answer. So
if I may add to that, sorry, Dr. Fisher, if I may add to that. So though it is covered, the patients who are seen at the university hospital, it would not, because it's not a primary government owned or managed hospital, the cost of those things are not necessarily covered. Or prescription would mean that if they carry it to a pharmacy, they do have to pay a significant cost. And even though when they get an NHF card that does help with some of the costs, it still ends up in being a significant challenge for many parents to afford the therapy. So prednisone steroids are going to be something that is easily accessible. I would say the calcineurin inhibitors, pretty much only the really well-insured two-parent households are able to afford that. And we really have to get really creative about, having some interface with the public healthcare system. So shout out to all my public pediatricians and rheumatologists and nephrologists to help us to source medication sometimes, but it really is a different situation at our center.
Okay, I think that those were most of the questions I saw in the chat, and I believe some of them were answered already by by Professor Silverman as well. But one was, is there a standard screening test that's done and a recommended frequency to screen for nephropathy in kidney disease, in lupus? If Dr. Young-Peart or Dr. Thomas would want to answer that question. Oh, wait, what? The mute.
Sorry, so because I had been kicked out before, I didn't see what Professor Silverman's answer was to that. But yes, you know, in addition to doing close monitoring of their blood pressure, making sure you take a good history every time they do come into clinic, which turns out to be about every 3 months, unless they're having an active flare, and then we do bring them back in shorter increments of time. However, we do I would say every 3 months on average, you know, we would be looking at the blood pressure. If they do have hypertension, we ask them to bring in home readings as well. Their urinalysis and microscopy would be done every 3 months. The biopsy sort of would only be done as clinically indicated, but we do spot urine protein to creatinine ratios at every 3 monthly intervals for the vast majority of patients who have demonstrated lupus nephritis. There may be times when cost challenges may mean that we don't get the results till another 6 months, but in the interim, you know, when they come into clinic, if it's even a bedside urine dipstick, we do try to do that as well to see how that could help.
Okay, and I think I have one more question before we end the segment because we're very behind. But I think Dr. Young-Peart actually addressed this in her presentation as well. What are some of the new medications for treatment of lupus nephritis?
So voclosporin is a calcineurin inhibitor that has been shown to be very effective in terms of being a good maintenance therapy medication. Belimumab is another monoclonal antibody that has been used to good effect as well. And there are another monoclonal antibody, I think it's another, I'm not remembering the name just now, but those are available worldwide. They are not available in Jamaica at this point in time.
All right, so I think at this point, I'd like to thank our presenters. Since, you know, we'll be here now, you know, for the rest of the day, we're kind of going to wrap up this segment on kidney disease. Thank you so much, Dr. Young-Peart and Dr. Thomas Chen, for really, really comprehensive talks on lupus nephritis in children. Please, guys, you know, feel free to post your question and answers in the talk, and hopefully in the course we will be responding to your answers. But thank you very much for your time, and I'm gonna thank our sponsors again for another talk on lupus in children. And thank you guys for your attention.
Very much, Dr. Lurie and Fisher. I must definitely commend you and your team, certainly, for how you so ably navigated through this topic, which does appear to have a bit of complexity to it. So I actually had to listen very keenly, and I liked how it was actually broken down in a way that many persons could understand it. And I certainly believe that many persons would appreciate the information that Dr. Thomas Allen and Dr. Sandrika Young-Peart relate to us. And despite the technological hitches that we may have had, that never stopped us. And I actually do again like to thank you, Dr. Lurie and Fisher, with how you handled it. Certainly, we expect that this matter of nephrology and how the kidney is treated is something that our person will take much more seriously going forward. And again, we look forward to more information, and definitely send in your questions. You can always log on to www.lupusfoundationofjamaica.org, or of course, you know, we can actually still take your questions if you register and just send them in, because all questions are important, certainly. And we would love to ensure we answer any concerns that you may have. So definitely thanks again, Dr. Lorian Fisher, and again, Dr. Thomas Chen, and of course, Dr. Sandrika Young-Peart. Right, so we will be going into a musical interlude. Of course, we did promise you entertainment. And of course, yes, we are going to give you some more entertainment. At this time, we would like to bring to bring to the fore the group. Hang on, just let me give it to you right now. Right. Right. So, Dedipia Sankara Arabesque. Okay. So, of course, from the music house, we have another performance, which of course will be done by Dedipia Sankara, called Arabesque. Please stay tuned and enjoy. Thank you very much.
Hi, my name is Dedipya. Did you know children who have lupus can have the same symptoms as adults with lupus? Life with lupus can be very hard. Join the fight.
Thank you very much. That was the piece Arabesque by the Music House, one of our piano students from the Music House. And of course, that was Dedipia Sankara. We will be going very quickly into Barant by, well, Alain Barant will be providing for us another bit of entertainment called Fur Elise. That's Alain Barant.
Hi, my name is Alien. Children and adults with lupus can be affected by hair loss, a butterfly rash across the cheeks and nose, and sores on the nose and mouth, among other symptoms. It is important for us to treat those affected with compassion and understanding. I support lupus awareness. Do you?
Thank you very much again. I certainly like to commend and to thank Elaine Baran for that piece called For Elise. And just before that, I would like to also again thank Dedipia Sunkara for her piece Arabesque. And certainly two really lovely pieces that we had actually promised. As we said, we're having good entertainment interspersed with good, robust conversation and discussion. Certainly couldn't have a better combination. You know, I'd like to, at this time, really thank our title sponsor, the National Health Fund, because without whom this entire production and feature would not have been possible, together with our gold sponsor, IPCA Laboratories, and our silver sponsors, Wysinco, Dr. Reddy's, and Carimed. These sponsors have been able to allow us to provide you with this really chock-full, rich symposium this year. And again, thanks to the National Health Fund, IPCA Laboratories, as I said earlier, our silver sponsors, Wysinco, Dr. Reddy's, and Carimed. It's interesting that we have another very interesting session coming up, which I'll tell you a little bit about. But before that, I would just like to remind you a little bit more about the Lupus Foundation of Jamaica. We are an organization that was founded in 1984. Yes, 1984. It's a volunteer organization, volunteer-run organization, of course, and we are registered under the Charities Association, the Charities Authority, and of course, regulated by the Department of Charities and Friendly Societies. Of course, our mission is to improve the outcomes of systemic lupus erythematosus to a better awareness and a deeper understanding of the disease. The disease, known very popularly as SLE, yes, systemic lupus erythematosus, is a chronic and lifelong disorder and immune system of the immune system, and the body's immune system becomes somewhat dysfunctional and attacking healthy tissues and leading to illnesses. I would like to, because we are sort of
Recording in
Most of us
progress.
will believe that it's a commitment to taking medications and prescribed therapies. However, in the small child and adolescent, we must encourage this commitment to themselves through, as Professor Silverman stated, honest, age-appropriate education on the importance of therapy and expected adverse events that they may come to experience. And with that, I'm going to go straight into introducing our first speaker and a friend, Dr. Donna Braham, who graduated from the University of the West Indies with a BS in biochemistry and zoology with honors, and went on to complete her MBBS and DM in internal medicine at the University of the West Indies. She had an interest in skin disorders and went to King's College in London, where she specialized in dermatology, where she received a master's in clinical dermatology with merit. Donna enjoys her work at the university as a consultant dermatologist, where she has accumulated experience in the management of rheumatology patients while working with one of our esteemed local rheumatologists in Montego Bay, Dr. Duquelier, who is here today. She's also the CEO and founder of Revolutionary Healthcare Limited and partner of Jamaica Allergy Clinic. Dr. Braham is also a member of the American College of Physicians, the Caribbean Dermatology Association, and the Dermatology Association of Jamaica, where she previously served as secretary. However, Donna's favorite role is that of a proud mother to her seven-year-old son, Sloan. And with that, Donna, I would like to invite you to share your screen to present on skin disease and body image in the child and adolescent with lupus, a very important topic, and one that I say is very important in adherence.
Thank you so much for that introduction, Raquel. Thank you so much to the presenters, the organizers of this conference, for asking me to give this talk. I will be speaking today on skin disease and body image in the child and adolescent with systemic lupus erythematosus. So my objectives are to give a quick overview on the cutaneous manifestations of systemic lupus erythematosus, to discuss the psychological impact of cutaneous lupus erythematosus and the management of cutaneous lupus erythematosus. Acute cutaneous, well, there are three major categories of lupus erythematosus. There is the acute cutaneous lupus erythematosus, subacute cutaneous lupus erythematosus, and chronic cutaneous lupus erythematosus. The association between acute, subacute, and chronic cutaneous lupus erythematosus really speaks to the long-term sequelae. So with acute cutaneous lupus erythematosus, there's most likely going to be systemic lupus. Actually, in all cases, there is systemic lupus erythematosus. Whilst with chronic cutaneous lupus erythematosus, there may not be associated, and there's a lower risk of there being associated systemic lupus erythematosus. With the acute and subacute cutaneous lupus erythematosus, there's less risk of long-term sequelae with the patient. So acute cutaneous lupus erythematosus may be categorized into localized acute cutaneous lupus erythematosus, in which case it may present with the typical malar or butterfly rash, where you get a thin erythematous plaque onto the cheeks, the nose, as well as onto the chin area. In the darker skin types, this may look more like hyperpigmentation or a violaceous hue. This, as I said, typically once treated will resolve usually without much post-inflammatory or hypopigmentation. May have generalized acute cutaneous lupus erythematosus. And in these patients, you may end up with palmar erythema. You may have erythema over the fingers itself, and this will extend in between the joints. You can have periungual erythema, as well as dilated nail fold capillaries that may be present, as well as you may have leukonychia, this whitish discoloration here to the nails. May have hair loss. In the acute cutaneous lupus, the hair loss tends to be a non-scarring alopecia, thankfully. And this may present in many different ways. It may be just a diffuse shedding of the hair, and this may be mild, or it may be more severe, where you have a severe shedding of the hair. You may get patchy hair loss, resembling that of alopecia areata. And then the most common is that of lupus hairs, where you get this very thin, lighter color strata, and this hair is much shorter, especially around the hairline. May also present with another generalized, you may also present with a toxic epidermal necrolysis type reaction, looking just like TEN from the drug reaction due to TEN, but this may actually be systemic lupus. And therefore, a collagen vascular screen should always be done whenever you're thinking of a toxic epidermal necrolysis, and should do the skin biopsy also with these patients. May present with a livedo reticularis type pattern. So you get this net-like erythema and bluish discoloration that occurs especially on the thighs. And that tends to be much worse when the patient is cold. Can present with vasculitic lesions, and you may get palpable purpura, and it may be papules, as well as it may be purpuric patches and plaques that are on the, especially on the lower limbs. Subacute cutaneous lupus is a photosensitive cutaneous eruption lasting longer than acute cutaneous lupus, but tends to resolve without much scarring. 10 to 15% of patients go on to have systemic findings. Typically, it presents as annular and arcuate erythematous scaly plaques on the back or the anterior chest, the trunk, or the upper limb, so in the photosensitive areas. May also have depigmented center and slightly atrophic centers, may end up with a psoriasiform plaque, as seen here on the legs. And this here is another photo showing the very annular lesions that are on the trunk. Chronic cutaneous lupus erythematosus, often interchangeably used to refer to the most common variant, which is discoid lupus erythematosus, but it also includes the less common variants such as lupus tumidus, lupus paniculitis, and chilblains lupus. Discoid lupus presents with chronic discoid lesions with permanent disfiguring scars, most often seen in the scalp, face, and ears. As Professor Silverman had said, don't forget to look into the ear. This is the most common location. You see it in the conchal bowl right here. And here you're seeing the pathognomic feature of discoid lupus, which is where you get this follicular plugging. So you see these hyperpigmented plaques, a little bit of depigmentation, and then you see these follicular plugging here, and there's some erythema that's there also. It tends to present with erythematous, well-demarcated, scaly pink plaques. This has here a crusted scale to it, and it can have a violaceous or hyperpigmented border, and there can be follicular plugging. When occurring in the scalp, this causes scarring alopecia, and therefore we have to be very aggressive with this condition. So even though this, especially in an adult, may not actually be associated with systemic lupus and may therefore have a very good prognosis, from the fact that it causes scarring, you have to be even more aggressive with this. If not, it causes significant psychological impact on the patient. And here is a photograph just showing you the very atrophic. You can see how sunken it is, scars that you can get from discoid lupus erythematosus. Also, with this chronic inflammation that can occur with discoid lupus erythematosus, you should always monitor these patients for squamous cell transformation. So especially in the long term, so not necessarily in the kids, but long-term lesions that have not been inactivated, have not been treated, and there's inflammation. If you see a scaly plaque or papule coming up, crusty lesion on it, that needs to be biopsied to rule out squamous cell carcinoma. Another thing that can occur with discoid lupus is that you may end up with secondary tinea infection, because tend to be using these steroid creams on it, especially in the scalp area here. And then you're wondering, what is happening? Why is the alopecia worsening? Now look for the black dots on these patients. This here is a picture of tumid lupus. So tumid lupus is characterized by photodistributed erythematous edematous smooth plaques without any epidermal involvement. Typically, these lesions resolve without sequelae, unlike other types of chronic cutaneous lupus erythematosus. And here we have a picture of the lupus paniculitis, which is considered a rare subtype of chronic cutaneous lupus erythematosus due to inflammation of the subcutaneous fat. It tends to present as tender, indurated subcutaneous nodules or plaques located most frequently on the face, proximal extremities, breast and buttocks, with or without overlying cutaneous changes. Whenever you have a lupus panniculitis with overlying discoid lupus, then that is termed lupus profundus. So common locations, we said the proximal extremities, face and chest. So, and this can therefore present with lipoatrophy, and that causes significant contour change, especially in the post-inflammatory stage. So this is lasting, and this, can be very, very distressing to patients. So we'll discuss some treatment options for that. Bullous systemic lupus erythematosus is another rare autoimmune blistering disease in patients with a known diagnosis of systemic lupus erythematosus or newly diagnosed with systemic lupus erythematosus. Patients must be worked up for systemic lupus erythematosus if they weren't diagnosed before and they present with bullous SLE. Typically, there will be associated lupus nephritis, and 45% of patients may have hematological abnormalities. 19% of patients may have neuropsychiatric involvement. It's typically a disease of young adulthood, affecting those between 20 and 40 years of age, especially females, as there is a major female predominance with SLE. And it typically presents as abrupt onset of tense vesicles and blisters on an erythematous background or on normal skin. May also get urticarial plaques, and they tend to occur on the face, trunk, extensive surfaces of the limbs are most commonly involved, body sites, and it may also involve the lips and the mouth. Typically, these lesions will heal with post-inflammatory hyperpigmentation. Here you're seeing some of the post-inflammatory hyperpigmentation that you may get, and you may also get milia. So those are little white papules or bumps looking, which is really keratin that's trapped underneath the skin. Neonatal lupus erythematosus is an autoimmune disorder of the newborn caused by placental transmission of maternal autoantibodies. Anti-Ro, anti-La, anti-UN1-RNP antibodies can be found in both the fetal and maternal circulation. The most frequently reported clinical manifestation of neonatal lupus erythematosus include autoimmune congenital heart block, which may be detected in utero, the cutaneous manifestations, autoimmune hepatitis, and cytopenias. So the skin manifestations, they may present at birth in 2/3 of patients, and the remainder appear by age of 5 months. The face is involved most frequently, but any body surface may be affected. Plaques generally heal within 1 year and typically present as erythematous scaly plaques on the periorbital or forehead distribution, otherwise called the raccoon sign. Although they may appear anywhere, and in darker skin phototypes, the erythema may be absent, replaced by hyperpigmentation or that violaceous hue. There may be persistent telangiectasia and atrophy, or just hypo or depigmentation after resolution. There are case reports actually of long-term hyper and pigmentation even into adolescence from having neonatal lupus. Here you're also seeing these very ill-defined fine papules and plaques with a fine scale on the chest and the arms, very photosensitive type distribution. And this may occur on baby's first photosensitizing event. Lupus, as I alluded to, is a cosmetically disfiguring condition, and its occurrence on easily visible skin, specifically the face and upper extremities, may have a profound impact on quality of life and psychological well-being, leading to anxiety, depression, and low self-esteem. Infancy, childhood, and adolescence each have their respective neuropsychological developmental stages that can be uniquely impacted by differences in cutaneous physical appearance. From early childhood, from early infancy until 3 years of age, self-image is shaped by the strength of attachment between child and his or her caregivers. The bond between infants and caregivers can be affected by the emotions parents have about having a child with a skin disorder or illness. And thus, the parents also need to be taken into consideration in a child who has lupus. May need to get counseling for the family also, so that this doesn't affect the child psychologically, well, further psychologically. At 2 to 10 years of age, relationships with peers increase in importance, and children may encounter teasing and bullying. During this critical time, children develop their body image, and by 7 years of age, children are able to recognize aesthetic differences between themselves and their peers. This recognition of physical differences can influence self-esteem. After 10 years of age and into the teenage years, children generally have lower self-esteem and are more pessimistic and self-critical. During these school age years and beyond, self-esteem manifests outwardly through children's motivation, confidence, and resilience. Young persons with SLE generally have severe disease at onset, as alluded to earlier in previous presentations, requiring high-dosed corticosteroids and immunosuppressive drugs for disease control. In children, SLE is associated with significant morbidity consequent to the disease. The treatment of SLE results in a wide-ranging spectrum of physical, functional, and psychological damage that impacts the well-being of children with SLE. The combination of active disease and side effects of corticosteroid treatment, such as weight gain, the moon face, facial rashes, physical inability, pain, hirsutism, having full-on beard, striae. Some of our drugs used to reduce the hypertension can cause significant hirsutism also, and the prednisone can do so. Striae, these patients can have terrible striae all over. Steroid-induced acne and hair loss may result in difficulties in daily life for adolescents with SLE. A prospective study analyzing disease activity and quality of life among patients with cutaneous lupus reported that disease involvement does not seem to directly correlate with an improvement in quality of life. This suggests that disease damage and subsequent cosmetic sequelae also play a role. Facial lesions, younger age, and female gender have been found to impair quality of life. Depression resulting from the disease increases appearance, concern, and dissatisfaction intensifies feelings of depression. So you see that it's a cycle. So how can we help? First, we need to have a high index of suspicion for psychological impact and reach out to our patients, speak with them. Remember that cutaneous lupus has a strong photosensitizing effect. So protection from sunlight, artificial sources of ultraviolet radiation, so both UVA and UVB radiation, as well as visible light, should be advised. We need to counsel our patients avoidance of potential photosensitizing drugs. Patients need to avoid UV exposure, avoid peak of sun exposure between 11 a.m. and 3 p.m. They need to avoid UV reflective surfaces. So going to the beach, water, snow, they have to be hypervigilant. It's not that they can't do it. It's just that they need to be very good about their sun protection at that time. At that time, you're not just wearing sunscreen, you're doing broad rim hats, sun protective clothing, etc. Need to wear UV, may need to get UV blocking films on the windows. Remember that UVA can actually penetrate windows. Tanning salons are an absolute no-no and can induce cutaneous lupus erythematosus, exacerbating pre-existing skin lesions. UV radiation has been shown to cause induction of organ involvement, especially lupus nephritis. May have to counsel our patients as to their career options, because an outdoor job with intensive sun exposure may not be the best job for that person. So example, being a roofer or a gardener that requires them being in the sun, regardless of how much sun protection you're doing, that's just still not going to be adequate on a daily basis. Remember that, as I said, there's UV radiation that's coming through the windscreen. So patients will tell you, but doc, I'm not in the sun. I get up in the morning, get dressed, and I just drive to work and I come back home. But you're sitting in traffic for 20 minutes and there's a lot of UV exposure that's actually coming in through the windscreen. We've had patients who can get flares from their lupus just by doing a long drive to the country, for example. In rare cases, the UV radiation from copy machines, from the fluorescent lights can also affect the patients. So these are simple little things that we have to be cognizant of. Visible light induces pigmentary changes, and it may also potentially exacerbate lupus. We need to counsel our patients regarding sunscreens. So yes, we spoke about the avoidance techniques, but sunscreens are of paramount importance with these patients. So they always come and say, what's the best sunscreen? I need you to recommend a sunscreen. That's kind of difficult because, to be honest with you, the best sunscreen is a sunscreen that you feel comfortable wearing every single day. But there are some recommendations with that. So you want to choose a sunscreen that has broad spectrum coverage. So it's covering both UVA and UVB. You need one that has an SPF factor of greater than or equal to 50. This 100 is not actually necessary because in reality, an SPF of greater than or equal to 50, of 50 is giving you about 95% protection. And really up to 70 is giving you 98. And you can't get to 100. So really getting an SPF of 100 or 110 is really not giving you that much more protection because there's nothing that's giving you 100% protection. These things are just going to be a little bit more irritating to the skin because the SPF is a calculation based off of the concentration of the ingredients that are in there. You want sunscreens that are containing iron oxides or physical sunscreens like titanium dioxide and iron oxide, because these prevent against the visible spectrum. You need to use a lot of sunscreen. So we have a tendency, because it has, especially the physical sunscreens, they have like a white cast onto it, which is not aesthetically pleasing. We tend to use just like a pea-size amount, but you actually need to use it at a 2 micrograms per centimeter squared concentration, which actually equates to approximately 1 ounce or a shot glass full of sunscreen to cover the entire body on a beach day. Or a teaspoon amount of sunscreen for the face and head and neck. At least 20, the sunscreen should be applied at least 20 minutes before sun exposure and daily use. And remember to apply the sunscreen onto the areas. So we all remember our face. Some may even remember the neck, but we forget the area. And remember the area to look for, for especially discoid lupus, the air. Why? Because that's an area of sun exposure that we tend to forget about. Always want to, sunscreen should ideally be reapplied every 2 hours and reapplied whenever wet or during extended sun exposure. Or medical management of cutaneous lupus erythematosus, the mainstay is going to be topical corticosteroids. Depending on the location, will vary the potency of the topical steroid. So definitely you do not want a high potency topical steroid onto the face or around the eyes. Especially high potency topical steroids, you want to use it no more than 2 weeks on, 2 weeks off, 2 weeks on. With that said, if you do have very recalcitrant lesions that are there, it's important to use it to settle it down. It's not like, okay, it's 2 weeks, let us stop using it. We can use occlusion, so cling wrap, so as to help the topical corticosteroids to penetrate even better. And we could do intralesional corticosteroids, so especially for things like discoid lupus erythematosus or tumid lupus or lupus panniculitis, we may want to do intralesional corticosteroids. Calcineurin inhibitors are brilliant in that at least it prevents all of the side effects of our corticosteroids, so the thinning of the skin, the telangiectasias that you can get with corticosteroids, as well as, remember, glaucoma, which is the reason why you don't want to use it around the eyes. Calcineurin inhibitors does not cause those things. They do cause a minimal burning in the initial stage, so you want to advise the patients about that. But they're great for especially like around the eyes, on the face, can induce a bit of acne, however. So here is a treatment algorithm that can be used for the treatment of patients with systemic lupus erythematosus. So usually you start hydroxychloroquine. And even if they don't have systemic lupus erythematosus, but if you have discoid lupus erythematosus, we would usually start hydroxychloroquine, at least in the initial stages also. So if there's good response, then you maintain. But if not, then you may want to add methotrexate to these patients. If there is good response, again, you may maintain, but otherwise, then you would want to stop the methotrexate and then to try oral retinoids. Remember that there are side effects with the oral retinoids. So there's the infertility. So especially in an adolescent, they need to be counseled regarding that and to be using oral contraceptives, well, 2 methods of contraception if they are sexually active, which hopefully they aren't. Retinoids are primarily useful in hypertrophic discoid lupus erythematosus, as well as refractory subacute cutaneous lupus and lichen planus overlap. Once you're on the retinoids, then you should discontinue methotrexate. Thalidomide can also be used, but this should only be used in severe refractory cases of cutaneous lupus erythematosus as a remission-inducing agent. And this should not be used with methotrexate either. Dapsone is brilliant. It's recommended for urticarial vasculitis, lupus erythematosus panniculitis, subacute cutaneous lupus, bullous systemic lupus, and oral ulcers. Again, cannot be used with methotrexate. And remember to always check your G6PD levels and ensure that's adequate prior to starting dapsone. Mycophenolate mofetil, primarily indicated in refractory subacute cutaneous lupus. But in general, once the systemic lupus erythematosus is being treated, the skin usually follows suit. Note that maintain refers to a certain period of time, depending on the agent and the efficacy and the type of cutaneous lupus erythematosus that is occurring. So after clearing of lesions, you should always try to reduce and maintain the effective dose or the minimum effective dose, or discontinue the medications as much as possible. But sunscreens should be used for the prevention of skin lesions forever. Although there's limited data, studies using cosmetic camouflage can have shown that there is improvement in the dermatology life quality index. So that's another thing that can be used. So they have makeups that are really brilliant to cover quite nicely, and they have the fixing powder so that it doesn't smudge. Also, there are institutions, there's like the Vichy institution, they will, you know, and multiple institutions that will actually teach you how to use the concealer and then contouring effects, etc., to help with depressions and to help with camouflage in that. For patients with alopecia, especially the non-scarring alopecia, so the thinning of the hair, you can use hair building fibers that comes as a hairspray, they come as a powder that can be applied to the hair, and that gives some coverage. Wigs are also another option. We don't like the braids. We don't like the extensions, the sewings, because that's going to put more traction onto the scalp. And that's just going to worsen the inflammation and cause the hair to fall out even quicker. Important to advise patients on stress management, and support groups have been shown to be quite helpful in the management of patients, both their family, their friends. It helps them to cope more easily with the daily difficulties of life, as well as difficulties of the illness. So kudos to Lupus Foundation and all the work that you guys have been doing, and keep it up. Cognitive behavioral therapy and appearance enhancement counseling have been found to improve body image and quality of life. So we spoke about post-inflammatory hyperpigmentation, that this is a common sequelae in patients with systemic lupus erythematosus, as well as cutaneous lupus erythematosus. One of the mainstay for the treatment of post-inflammatory hyperpigmentation is sunscreen, and treating the underlying lesion as quickly as possible, because the quicker you settle down the inflammation, the less post-inflammatory hyperpigmentation there will be. However, for pigmentation that's there, we can use skin lightening agents such as hydroquinone, retinoids, azelaic acid, arbutin, chemical peels can also be done. We spoke about stretch mark striae, common side effect, especially when they have the weight gain and obesity with the prednisone, whenever they're anasarca with the renal impairment and nephrotic syndrome. Topical tretinoin at 0.1% has been shown to be effective in the management of early stretch marks. So you actually want to catch them when they're pinky purpley in color. Fractional ablative carbon dioxide laser treatment is another option. Slightly limited, especially in the darker skin types, but can also be done. Pulse dye laser therapy can also be done. There was a lot of hesitation regarding using lasers in systemic lupus in the past, especially since this is a photosensitizing disorder. But there are multiple studies showing that at low fluencies, it is safe and it actually does help and can be used for treatment of even active disease. So it does help to settle down some of the erythema and decrease the scarring that can occur thereafter. Injectables, remember I spoke about panniculitis and the lipoatrophy that you can get. And again, injectables was something that in general we didn't want to do before because of fear of reactivation caused by tissue stimulation. And that still is a bit of a concern, but there are multiple studies showing that fat transfer has been done successfully and without any major problems, but it must be done during a period of quiescent disease because, you can get fat emboli and coagulopathy is also something that can occur in lupus, especially when they're flaring. Fillers can also be used. Hyaluronic acid, polylactic acid can also be used. Hyaluronic acid, there have been reports of long-term, so greater than a year out, of getting these inflammatory nodules underneath the skin with HA fillers that tend to be very resistant and require injections with both hyaluronidases as well as steroids. So in summary, cutaneous lupus erythematosus lesions are photosensitive and may leave scarring, which may have significant psychological impact, especially in children and adolescents. In general, in addition to medical management of these patients, physicians should be aware of the psychological impact to offer cosmetic options where possible. Here are my references, and thank you. Sorry for going over time a little bit. Any questions at all?
Thank you, Dr. Donna Graham. Wow, that was quite a mouthful and learned quite a bit. In regards to time, I'm just going to take a comment from the chat that Nicole Johnson mentioned that sunscreen that blends well with black complexion is an issue. So for instance, the caregiver or the parent putting on sunscreen and having to send the child to school. Have you found any that are more neutral, I should say, similar to the pantyhose story for black skin, very dark skin?
All right, so the ones that blend the nicest are the chemical sunscreens. They're not my favorite. So what we tend to do is to use what we prefer are the ones that have the physical sunscreens, and those are the ones that have the white color in them. But what you can do is to get the tinted versions of it. There is also a product that I quite like. I'm not sure if I'm allowed to be using brand names, but anyways, Color Science Unforgettable also has like mineral powders, as well as there are lots of different brands, Black Magic, Black Opal, Better Science, Skin Better. They have lots of different mineralized powders, which also do serve as a sunscreen. So what I suggest is that you put on your physical sunscreen, which is one that tends to have some physical and chemical blockers, so it's a little bit thinner, and then you apply that mineral powder onto it. The Color Science that I love has a brush, so it makes it a lot easier to just carry around, to just brush it on every 2 hours. In Jamaica, we don't have a great sunscreen selection, but there is Australian Gold out here, which I quite like also, and Sunbum. Neutrogena Healthy Defense is another light one that goes on quite nicely. I see Fontana now with La Roche. Love La Roche products. They have some very thinner, not as thick feeling, but yet still they have the titanium and the iron oxides.
Thank you so much for that. There's a ton of questions that I myself would love to ask, and I'll have to do that at another time because we're pressed for time. I just want to give a warm round of applause to Dr. Graham for informing us on the scarring and photosensitive issues involved with the issues with lupus in children. Thank you, Dr. Braham. And I'm sure you'll
thank you so much for having me.
leave your contact information for further questioning, or
I
we
sure
can
will.
placed in the chat. So stick around. I'm going to go on next to our next speaker, who has a very interesting background. This person is Dr. Winsome Beverly Christie. For over 3 decades, Dr. Winsome Beverly Christie has been giving sterling service to our medical industry. Her dexterity in the medical field spans 2 important roles. She's first a naturopathic doctor, and that is one who practices traditional medicine. And she's also a clinical pharmacist. Further evidence of her expertise is seen in the fact that her work has been instrumental in the addition to the local medical tourism industry, where patients from as far as Canada, the US, United Kingdom, and several islands in the Caribbean seek her services. She has a passion for alternative medicine, which is manifested in the fact that she established the first integrated health and medicine pharmacy in Jamaica, which provides high quality and affordable healthcare to all. At the community level, Dr. Christie is involved heavily in outreach activities. One such activity is the National Council on Drug Abuse, which extends to the provision of counseling sessions for persons with substance abuse issues. She also is involved in capacity building programs for health professionals in government and private institutions, which is part of her professional repertoire. Presently, Dr. Christie is the president of the Pharmaceutical Society of Jamaica, the professional body of our pharmacists, which helps to promote its mission of promoting health and serving the society. Please welcome Dr. Winsome Christie on her talk, Adherence in Children, in Practical Therapies and Promoting Adherence in Children and Adolescents. Dr. Christie, go ahead.
Thank you very much, Dr. Lowe Jones, for your introduction. And I would like to thank Dr. Tola Reid and her team for inviting me here to speak to you all this afternoon on practical therapeutics and promoting adherence in children and adolescents living with lupus. Because of the time constraints, I will be going quite quickly. I'll be trying to discuss the medications used in the illness. I will try and limit it to the ones that's more popular in Jamaica. I will discuss a few of the side effects and give some clinical pearls for how medications can be used in a way that's beneficial to the patient, in this case, the child, and helps the caregiver to ensure that the child is compliant. So the treatment for children is similar to those in adults. We use the corticosteroids. In mild lupus, the immunosuppressants, NSAIDs for the musculoskeletal symptoms. For moderate lupus, we use azathioprine or mycophenolate, especially if there's renal involvement or hematologic issues. For severe lupus, we use a cyclophosphamide or rituximab, especially if you have CNS involvement or severe kidney or hematologic disease. A new monoclonal antibody, balimumbab, is also being used, as well as the calcineurin inhibitors, tacrolimus and cyclosporine, which is advocated in multi-drug therapy for pediatric lupus. Did mention about NSAIDs, like aspirin, ibuprofen, and naproxen, which are used in mild lupus to control some of the symptoms. Antimalarial drugs like hydroxychloroquine. The maximum dose is 400 milligrams and can be given in 2 divided doses. These can be crushed and made into a suspension for the patient. The dose has to be reduced in hepatic impairment and renal impairments. And in patients with glucose 6-phosphate dehydrogenase deficiency, it has to be monitored because it can cause hemolytic anemia. There's retinal toxicity, which is reversible upon discontinuation. And there are GI disturbances such as nausea, vomiting, which is consistent with a lot of the other drugs used in lupus. Corticosteroids such as prednisone, the side effects that concern teens and young children is weight gain. The mood changes and depression are quite significant because already they have this disease that's limiting their activity, restricting their movements. This will cause depression and other mood changes in addition now to these medications. Long-term use will cause osteoporosis and other bone complications, increased infections, other illnesses like diabetes or high blood pressure. And we did mention GI upset. For GI upsets, we would recommend as pharmacists to give the medication while the child is eating, or for those who can tolerate milk, not many persons these days, we give with milk or recommend to be given with milk, or you can use milk substitutes to reduce the upset. The dietary intake of phosphorus, calcium, vitamin C, vitamin D, folate, and pyridoxine, which we can get from our vegetables and fruits, need to be done because of the reduction that occurs once on steroids, and which need to be monitored in kidney disease. The frequency for dosing this medication is 1 to 4 times a day. So this frequency can cause a compliance issue. So practitioners might be encouraged to possibly reduce it to a twice daily dosing. And so you might give higher doses and eliminate the in-between doses to encourage compliance. These again can be reconstituted by crushing and added to a diluent to administer to the child if they're having difficulty swallowing the large amounts that may be prescribed in crisis. We would not recommend dissolving in the mouth because these are quite bitter. And as pharmacists, when we constitute these, we use syrups to mask the taste. There are a lot of drug interactions that happen with these immunosuppressants and systemic corticosteroids. I won't be going into all of them because of the time constraint, but basically using this lexicon interaction database, we see that items are in X. These are items that must not be combined at all. We see there are a lot of vaccines that mustn't be given at all with the corticosteroids. That's because they actually reduce their action. For those items with D on it, it means it's not recommended to be given, but you can give, but it would be a good idea to modify the therapy. We see the COVID-19 vaccines, the mRNA vaccines, the Pfizer and the Moderna vaccines fall under this category. The management recommendations for giving the COVID-19 vaccines for these children. Well, of course, in Jamaica, we don't have the authority to give under 12 years old, right? We haven't gotten that authorization. But in the population that we're giving now, you would discontinue, you would taper off the steroid and give the vaccine, or you give the vaccine before you initiate the steroid. Of course, you cannot tell when you're going to give the steroid because that you give it when there's a crisis. So hopefully the practitioners will be able to sort this dilemma out. You have other, like the adenovirus vaccines or the AstraZeneca. You would monitor if giving along with steroids. But for us in Jamaica, we're not using AstraZeneca in the children population. Immunosuppressive drugs now like azathioprine, cyclophosphamide, all listed here. For lupus nephritis, we see that calcineurin inhibitors like cyclosporin and tacrolimus are given. Cyclosporin is a parenteral drug given by IV infusion, and this is now being given as a multi-drug therapy, as the clinicians, especially in this research here, found that cyclosporin and tacrolimus maybe less cytotoxic and attractive therapy options for young patients who have lupus nephritis. Cyclophosphamide, takeaway point here is treatment beyond 90 days have a potential for sterility in males. So you would really want to reduce the length of time for male patients, the young boys. Again, cyclophosphamide causes hemorrhagic cystitis. If it's severe, you discontinue the treatment. In renal impairment, you would need to be adjusting the dose, especially if the creatinine clearance is less than 10 ml per minute. And then there are other conditions here with hemodialysis, peritoneal dialysis, where the percent dose needs to be reduced. In hepatic impairment, there's generally no adjustment, but if the bilirubin is 3.1 to 5 milligram per DL, or the transaminases are 3 times the upper limit of normal, then you would give 75% of the dose. Side effects of cyclophosphamide we want to watch out for is the nausea and vomiting. You wouldn't administer the dose at bedtime. This is because of the hemorrhagic cystitis, the bladder infection that might occur. If you give in the morning, then there's more chance you try to hydrate the patient throughout the day to ensure that it doesn't get concentrated and affects the bladder. That side effect will be reduced. However, if the patient is having renal issues, then you still have to monitor how much fluid is being given. Oral solutions must not be made by crushing the cyclophosphamide tablet, which at this time is scarce, but when you do have it, you do not crush them. You use the injection to make the solution. And so this point here is to emphasize to patients, caregivers, children, it's not all tablets and capsules that can be crushed or capsules that can be opened and used. You have to follow the guidance from the pharmacist or your medical practitioner, how to give an oral dose that may be liquid if the child is having problems swallowing the tablets. So cyclophosphamide, and you'll see a lot of the others, are made from the injections to give an oral solution, not the tablet form if available. Again, this solution, this is just outlining how it's made, but you shake the solution well before giving, and you can keep it in a refrigerator for say 60 days, 56 days, 2 months. The side effects include the bladder toxicity we mentioned, slow wound healing. For children, we know they're going to fall over, they're going to trip, cut their knees, etc. Their wounds are not going to heal as quickly as regular children. So you have to take them to the doctor to ensure that they get their antibiotics, that the wound is monitored to ensure it heals satisfactorily. Other malignancies might develop because of the use of the drug. The hair and skin might get darkened. The urine may become dark at times. There might be abdominal pain, hair loss, some side effects noteworthy with cyclophosphamide. Methotrexate, this one you give on an empty stomach. Now, some persons have issues with what is an empty stomach. An hour or 2 before eating means there's no food in the stomach, right? Now, if you cannot take the pill on an empty stomach, then 3 to 4, the literature will say 2 hours, but for those who may have a sluggish digestive system, meaning the food is not moving through fast enough, then you can say 3 to 4 hours after eating, you can take the medication, because that time the food have gone out of the system. And when you take the medication, then there will be no interaction. All right, so for methotrexate, it's recommended you can use any drink except water to swallow the pills, okay? And you need to use a calibrated spoon, not a household spoon, to administer medication. Because of the nausea and vomiting that it causes, you can give antiemetics before administering the drug. So that can be given probably an hour before, so that by the time you take the medication, the stomach would be settled and the vomiting wouldn't be there. The drug can be given intravenously, intramuscularly, subcutaneous, or intrathecally. When you use intrathecal method, it must be preservative free. and all solutions can be stored at cool temperatures or in a refrigerator. Dosage adjustments are needed in renal impairment and hepatic impairment, and folic acid supplementation needs to be given whilst on this drug because it interrupts the methylation cycle. And a point to note, it must be taken on the same day as the methotrexate. Again, solution, the oral solution is made by using injection, not the pills. Mycophenolate, you have two presentations of this drug. You have the delayed release drug and you have the immediate release drug. The delayed release drug can be taken on an empty stomach to avoid changes or variability in the absorption that happens with food. And this is in stable persons. Now, in renal transplant patients who are stable, then it's given with food. So sometimes when you come to the pharmacy, you may find that a pharmacist may say, oh, you can take this food with, take this medication with food, or you can take it without. It doesn't matter. Studies show, for example, mycophenolate, that the overall absorptions after taking the drug, the overall effect of the drug is not really affected by food. So that's why you can have this variability, and sometimes a pharmacist can say, oh, you don't need to worry about with or after meals. You can take the drug anytime you like. It's because of these type of variabilities, all right? The suspensions, again, shake well before use and can be administered in a nasogastric tube for those patients who do that with their loved ones. It's not to be mixed with other medications or liquids. You swallow the capsules or tablets whole, no crushing, no opening. Now, if you miss the dose, you take the next dose, you take it when you remember. However, if it's 2 hours, for example, the next dose is 2 hours away, then it's advisable to just forget that missed dose and just go back to your regular schedule. But other than that, if you have a long time between the dose missed, the missed dose or the one you forgot, and the next dose on your schedule, then you can take the dose you forgot. Again, now for the delayed release, we said 1 hour before, 3 hours after eating. A point to note, the 720 milligram twice a day delayed release is equivalent to 1,000 milligrams BD of the mycophenolate mofetil presentation, which is the immediate release, okay? And this drug can be used in lupus nephritis and the nephrotic syndrome. Rituximab is the monoclonal antibody, which acts on the proteins in the body that would be overreactive when faced with an immune status, which is what's happening with lupus, an overactive immune system. It's a lot in the literature, it's the uses off-label, it falls on the off-label uses for children, pediatric, and the nephrotic syndrome. The dose is 375 milligram per meter squared, weekly for 4 doses to a maximum of 500 milligram. For refractory cases in greater than 6-year-olds and adolescents, they go to the low dose of 187.5 milligram on day 1, once weekly for 1 to 3 doses on day 8, 15, and 22, counting after the first dose. Or sometimes they might just omit that low dose and go from 375 milligrams per meter squared and give it on days 8, 15, and 22. If they do use like 750 milligram per meter squared, then they might just give it on days 1 and 15. There's no dosage adjustment needed in renal hepatic impairment. So for SLE that's refractory, the clinician has a wide range of how they may want to dose the patient. Side effects for rituximab include neutropenia, bowel obstruction, cardiovascular effects, hematologic effects, and hepatitis B reactivation, frequent infections, infusion-related toxicities, and other renal issues. Belimumab is a new monoclonal antibody. This one is given, and when it's being administered, it helps to reduce the doses of the steroids, which have these troubling side effects, the weight gain with the moon phase, which affects these young people, and of course, other age groups. It actually is specific for the B lymphocyte stimulator protein so that the B cell mediated immunity and auto-response is reduced. There are other experimental medications that's being done, and I'm not sure if it's the case in Jamaica at this time, where clinical trials can be done for new drugs. And so patients can be encouraged to join them if they want to try newer methods of treatment. Other medications used, diuretics, anticoagulants, biphosphonates. These would be for the other illnesses that develop as a result of this multi-system illness that affects all the body organs in the body. We also have supplements that can be used. We see the need for folic acid when methotrexate is being given. B12 we know is important and becomes deficient when some medications are given. Vitamin D, zinc, all of these minerals here are also linked to depression. So sometimes you can improve the depression that occurs with these young people or in other patient groups by looking at their mineral status. And so nowadays, persons not only test for these ANAs and all these other markers for lupus, but they do mineral tests to see what's happening with the mineral status of the patient. Also, other anti-inflammatory markers or other inflammatory markers are tests like the interleukins, homocysteine, and so on, to see how well the disease with this inflammation is progressing. Challenges to adherence for children and adolescents now. The family involvement. Sometimes you don't have the family involvement. Parents are a bit lackadaisical in following up with the treatments, with the tests. They might not see the relevance. Sometimes too, it may be just frustration because of the amount of tests being done and no conclusive diagnosis. The length of time taken to make these diagnoses, the frequent lab tests, you know. Right now, there's concern with immune status and the increased ability of these children to contract COVID-19 and the lack of availability of vaccines for this age group, that is below 12, right? And so all of these will generate stress, not only on the family, but also on the children. So hence the need, one of my colleagues mentioned, for counseling for family members, for them to help to deal with this stress, that's this added stress that's being placed on them. Also the financial problems that may arise. If the drug is not available in the public sector, then they have to go to the private, and the drugs may not be covered by the National Health Fund, which is doing a good job at the moment in providing subsidies. In fact, for children, once they need supplementation, they get a double subsidy, which is great. But then when they transition now from childhood to adolescence or older age group, where those double subsidies are reduced, then you can imagine the financial burden that occurs. There's problems with school accommodation. They miss days at school because of the illness or because of an appointment. The side effects that happen, so many pills that need to be taken in this young age group, those are all issues. And when pharmacists counsel, they have to address all of these social issues. Sometimes people can't afford things. You have the social determinants of health that we as pharmacists have to be addressing. So you're acting as a social worker in addition to providing technical and scientific information. When children transition to adult, now this is challenging because, you know, you're born as a young child, oh, I'm growing up, I'm supposed to be doing this, I'm doing that. Yes, so you're now subjected with this very limiting illness. The invincibility that adolescents feel is taken away from them. So you can understand the depression. When you have to change from the primary care physician and specialist area like Bustamante to Kingston Public Hospital or University Hospital of West Indies or Cornwall Regional, or these other adult facilities. The pharmacists who we spoke to in doing this presentation mentioned that they're concerned because they seem to feel as if they've lost these patients once they transition. And in trying to speak to the other pharmacists at these adult facilities, they are not clear where these patients are and what's happening. So as president of the Pharmaceutical Society of Jamaica, we are during Pharmacy Week concentrating on having outreach posts in these different health facilities and trying to target clinics and educate the clients in a group setting. But we need to therefore be doing this on a more regular basis and targeting these specialist groups to help them, give them the support that they were getting at the Bustamante Children's Hospital and other facilities. When they change their physical location, get a new job, go to college, that's also an issue. Change of insurance coverage. When they get older, they're no longer covered by the insurance. As we said, NHF, the double subsidy is removed. Balancing the adult responsibilities and managing this chronic illness are also issues. Family changes, family relationships, and pregnancy, which is extremely challenging, that is another issue as they transition. Now, I had some cases, I took them out because of the time. Now, these cases were featuring 9, 11, 16, and 17-year-olds and 12-year-olds. So just summarizing some of the issues they had weight gain due to the medication and steroids, and that is what the pharmacists found when they were interviewing some of the patients when they counseled them. They have to be counseling them how to deal with this weight gain and encourage them still to take the medication. And possibly this is where you have the multidisciplinary approach. You need a nutritionist on board now or a dietitian who can then guide them to help them see how they can lose this extra weight, what exercise methods they can do so that they become comfortable with themselves and this new identity. The depression that can occur during our counseling session, we can use DMS-5 tools to see how far they are in the depression, and they may need to be referred to another specialist, a psychiatrist, who will then help them through this depression. The other illnesses that arise, counsel them on how they can now cope with it, the dietary measures they need to take, which can help, and also the need for exercise and healthy eating. Then you have drug-induced SLE that occurred. In one patient, it was because of the drug minocycline. Some drugs cause lupus too, like the attention deficit hyperactivity medication. The stimulants used there can cause lupus. So as pharmacists, we have to look out for this. In this one patient, though, after discontinuation of the minocycline and 6 months treatment with hydroxychloroquine, the symptoms resolved. One of the cases illustrated how the disease can progress from in the teenage years to symptoms of an adult. The complications that can arise in the disease despite treatment, such as blood clots in the abdomen. Right, so those were the issues that came up. Pregnancy and lupus, when we look at the interactions using the drug database, there was no interaction with azathioprine, cyclophosphamide, mycophenolate, methotrexate, and hydroxychloroquine. So those contraceptives can be used during administration with these medications. It was only prednisone that had an issue, but it was the concentration of the prednisone that was increased because of the contraceptives. So again, monitoring needs to be done once on the prednisone and contraceptives. But despite the fact that pregnancies are high risk for lupus patients, in Jamaica, we have a good system where persons are able to get pregnant and have healthy babies, despite the complications that can occur. Challenges to adherence, the initially long time it takes to diagnose, up and down, frequent testing, going from this side to that side to get the medication, the large amount of tablets to be taken, the side effects of medicines. Access to pharmacy sites to obtain the medicines was one thing that the pharmacist brought up. The restrictive coverage of medication for lupus on the National Insurance Scheme, the National Health Fund. What was happening there is the drugs for lupus would sometimes be covered under diabetes. And if you don't have diabetes, then you cannot access the coverage for that drug. So suggestion here is the Lupus Foundation or can always approach the NHF, who are excellent in trying to provide as best coverage for the Jamaican populace as possible, to mention the drugs that they need coverage for under lupus, and then it can be updated, because the NHF does update from time to time, The long wait time for medication, transport challenges to get supplies from centers, and what came out here is the pharmacist was saying she believes we need more pharmacists who are involved in a private-public partnership so that the patients can have a greater access to affordable healthcare. At the moment, it's limited and persons have to be going extreme distances, paying bus fares from earnings that they don't have to get the medication. So those can pose problems to adherence. But some positive.
Dr. Christie.
Excuse me?
Unfortunately, this is Dr. Lowe Jones. I'm sorry,
Okay.
we're really running behind time. If you want to wrap up with this final slide or say a few words.
Okay, I'll just wrap up with this one. In addition to the counseling, we can encourage mindfulness sessions, just as how we saw the lovely performances from these students, get them occupied in extracurricular activities, which helps their mind to be relaxed. We see mindfulness helps to decrease the heart rate, blood pressure, respiratory rate, and other deleterious effects that the lupus does cause. So that I thank you.
Thank you very, very much, Dr. Christie. That was an excellent presentation. And thank you for highlighting some of the challenges with adherence. For questions for Dr. Christie, could the participants please put their questions in the chat? And Dr. Christie, I'm sure you'll stay on to help answer some of these.
I will, thank you.
Okay, great. As Madam Speaker, Madam President, I believe we're going to go right into the next session because we're quite behind, and we're going into session about, we're going to have a short film on patient perspective, Voices of Lupus Warriors.
Right, as I'd like to first thank very quickly Dr. Raquel Lowe Jones, and she's absolutely correct that we are certainly running behind time. So as we move towards the ending of our symposium, I certainly like to ask your permission that we will skip over one of the video montages, which we can make available at a later date, or perhaps put on YouTube. But we'd like to move into, and yes, we will actually squeeze in a artistic piece by Kiana Jackson just before we get into section 4. So we have 2 sections coming, and these are the Adolescent and Lupus, and this will be moderated by Dr. Karel Decula. And of course, the final segment will be by Dr. Vivette Swavey. So let us go very quickly into that section. We do apologize for the issue with time, but of course, we have to find a creative way to make up for it. So right now, we will actually move into the creative piece by our lupus warrior, Kiana Jackson. And then we'll be having, of course, a very enlightening panel discussion at the end of section 5. So, ladies and gentlemen, do bear with us and stay tuned for this piece by Kiana Jackson. Perhaps
shout out to the wolves and the butterflies. Them nasty, the fatigue in our eyes. So we in a pain and feel the old age. All them thing they raise my rage, but me get for understand say cause them don't know. And then we struggles don't really show. But me nah go hold it done no more. I bring it pan a level tired for feel look. How we a lupus warrior, lupus fighter. Me a represent as a freedom writer. Countless times me say me go next to death. Thank you, Father, you never take away my breath. But any type of pain, you name it, no cure but healing. Yeah, me have to clear me more, I'm even give up, but this is a war. Right now, me can't even count my scars, and we are rise up. So listen to the truth. Not for we are fight from, we are little youth. Today we go down, tomorrow we bad. Right now me I wonder, how me no mad. Remember this, me couldn't breathe in a bed, couldn't move. Them laugh after me when me in a high school. Lose so much weight, couldn't recognize myself. I was just a joke to everybody else. Couldn't beat, couldn't eat, couldn't even hold a pen. Did I for wonder if the pain the dagger end when me see how much pill me have to take a day. Just got that palm my knees and pray no come for cause no trouble. Just to make you know a little bit of the struggle. If words could attack you would have done know the juggle. If words could attack you would have done know the juggle. I saw we knew who real. Big up all who stick with we on the battlefield. Big up all of them who help we heal. Cause you don't know I said the war is real. So shout out to the wolves and the butterflies. Them nasty, the fatigue in our eyes. See we in a pain and feel all age. All them thing they raise my rage, but me get for understand say cause them don't know. And then we struggles don't really show. But me nah go hold it done no more. I bring it pan a level tired for feel look. We a lupus warrior, lupus fighter. Me a represent as a freedom writer. Countless times me some go next to death. Thank you, Father, you never take away my breath. Any type of pain, you name it, no cure but healing. Yeah, me have to clear me more, I'm fever give up, but this is a war. Right now, me can't even count my scars and we are rise up. So listen to the truth. Not for we are fight from, we are little youth. Today, we go down, tomorrow we bad. Our praises to the Most High God, cause we are lupus warrior, lupus fighter, lupus warrior, lupus fighter, lupus warrior, lupus fighter, lupus warrior, lupus fighter.
So thank you very much once more. I'd like to give credit again to our lupus warrior, Keynote Jackson. But of course, we would like to definitely appreciate the work and the sponsorship of our title sponsors, the National Health Fund, doing a great work with logistics and providing medication for all of Jamaica. The Lupus Foundation is definitely indebted to them. Very good. Thank you very much also to our silver sponsor, that is our gold rather, that is IPCA Laboratories. And of course, our silver sponsors are Wisinco, Dr. Reddy's, and Caramed. Again, without these sponsors, today's event would definitely not have been as successful as it is. And we have had a chock full of information, rich information from all the speakers so far. Despite us being a little bit behind time, I'd like to now take the opportunity to thank, of course, our next moderator, actually, who will be speaking to us on section 4 is Dr. Karel Akula. Dr. Karel Akula is a consultant rheumatologist and a very well-known president of the Lupus Foundation of Jamaica. He's actually President Emeritus. So Dr. DeCula will be taking us through section 4, which will basically be speaking to the adolescents and lupus. So let us welcome Dr. DeCula at this time. We will be sorting out the technical issues why we're not getting the audio from Dr. DeCula, because I'm sure you definitely do not want to miss his presentation, but we're sorting it out, and we'll be with you very shortly. Right, okay. Well, as we sort that matter out, we actually have to indicate, well, there's a small matter that I wanted to raise with you, which was, did you know that as eloquently, really, and as well articulated as Dr. Graham said it, that most lupus occurs within young women at the age of 22. And however, this disease, which can also affect males, has been diagnosed in different age groups with up to 20% in children. People from African descent living in the Caribbean and North America have the highest prevalence of lupus. A few notes that you may want to bear in mind. Right. So Dr. Abigail Harrison, who will be, or will be up next actually, is a pediatrician and a lecturer in consultant pediatrician and adolescent medicine, subspecialist in the Department of Child and Adolescent Health at the University of the West Indies and the University Hospital of the West Indies. She received her undergraduate medical and postgraduate training in pediatrics at the University of the West Indies, and then completed a clinical fellowship in adolescent medicine at the Hospital for Sick Children. Dr. Harrison's research interests include delivery of healthcare services in adolescents, adolescents living with chronic illnesses, adolescent resilience, and disordered eating behaviors in adolescents. Very well-renowned doctor. Dr. Abigail Harrison, please let us give her your full attention.
Thank you, Mr. Smith. Good afternoon, everybody. It's my pleasure to be here this afternoon. And I just want to thank Desiree and her team for all the hard work they're doing and for helping me to join them with this hard work today. So I'm just gonna try and get the presentation up and started. Okay, so we're gonna quickly move through and look at transition of the adolescent who is living with lupus. I have no conflicts of interest to disclose, so we'll just get right into it. So the question you might be asking is, why is the transition period important? So really, this is not unique to SLE. However, during the transition period for young persons living with lupus, we do notice that there's an increased risk of worsened symptom and disease control, increased risk of morbidity and mortality. And in fact, the mortality rate for childhood onset lupus is 2 to 3 times more than that for adult onset SLE. And this often peaks in young adulthood, pointing to period as being very important. That time when you move from pediatric-based care to adult-based care. It also is a time when they are oftentimes struggling with daily living activities in comparison to healthy adults. Now, in addition to having moderately high disease activity in this period, some of the other challenges that we note in terms of the transition space is that there may be an extended time between their last pediatric visit and their first visit at the adult clinic. And this can go anywhere between 4 and 8 months, and sometimes even up to 1.5 years, Sun and his colleagues noted. And one of the big concerns is that gap in care, where there may be a delay or missed visits. In fact, they found that almost a third of young persons were missing more than one visit in their first 2 years post-transfer. Now, the adolescent patient living with lupus or any other chronic illness, and when we talk about adolescent, generally it's considered age 10 to 19, certainly by the World Health Organization, but I put plus because really this space of time can go up to 24, 25 years of age. And we really have to consider the developmental perspectives, their cognitive development, that capacity for abstract thought, to start thinking about what I do know, how it will impact my life later on. And that is something that's just coming into play as they start going through adolescence. They're also going through this time of figuring out who they are. So that space of figuring out their identity versus confusion about what their role in this world is. There's a lot of impact on social brain development when you have a chronic illness, particularly one that may result in many missed days at school. And certainly with COVID and that loss of social interaction, there is significant impact on the young person. Many of the speakers prior to myself also spoke about things that affect development and progress of peer acceptance. So body image issues, Donna just spoke at length about that. You know, many of them may look younger in appearance. Many of them may be shorter. Many of them may have delayed puberty, and all of that can play into it, in addition to all the issues with their skin or with weight gain with their medications, as was also mentioned in detail. So transition, what is it really that we're talking about? Probably the best accepted definition is the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. And really what it is a process. It's not a one-time event of movement. And it really should begin years before and continue years after transfer. The goal should be to ensure that the patients are engaged in their care, they have adequate access to care, and that they understand that there's an increasing expectation for them to manage their own care. So, transition, the process, really, we have to consider quite a few things. The specific underlying medical illness, and here we may have lupus, yes, but there may be other comorbid illnesses. We have to look at the adolescent's age, whether not just looking at their chronological age, but also their developmental age, which may be delayed. So things that they may be able to manage doing, they can't manage to do that now. In terms of considering that transfer of primary responsibility of care from the parent or the healthcare provider now to the adolescent. And we can't just drop it on their lap and say, oh, well, you turned 18, so now you know what to do. It has to be a process where we hand those responsibilities over slowly. There needs to be structured preparation, and we have to ensure that before we have that transfer to the new clinic, that they have skills to cope with their health condition. So what are some of the recommendations to ensure or to optimize the likelihood of a successful transition? 1, we need to have a written transition policy. 2, we want to start early in adolescence. So most persons will recommend starting between age 10 and 12. You want to have an individualized transition plan based on the unique strengths and challenges of each particular young person and their family. And we take into consideration medical, psychosocial, educational, and vocational factors. And then there must be a detailed transfer summary, not a 2 or 3 liner, but summarizing some of those strengths and challenges so that the adult provider will know how best to work with this young person. And definitely there must be direct communication between the pediatric and the adult provider. Now, White and Cooley put together a really nice timeline for introducing the 6 core elements that we feel facilitate successful transition. And this takes from having the transition policy, tracking and monitoring what's going on between the time you start to the time you're ready to transfer, assessing their transition readiness, making sure that you have a specific plan which is discussed with and cleared by the adolescent, and also discussed with the parent or the guardian so that they're also on board with it. And then we have the transfer of the documentation and the transfer of care, and then the patient goes across. Okay. Now, the transitioning adolescent, really we want them to be able to recognize their symptomatology and have that ability to communicate adequately on their own with their healthcare team and or their parents and caregiver. And then thirdly, we want them to be able to manage their disease while fitting in with their peers. Now, one of the key factors is health literacy. So communication skills depend on how much you know and how much you can transfer to the person who is listening to you. And one of the elements that I think can be very useful, and this is something that was introduced in the Good to Go transition program, which we actually started using in the lupus clinic where Prof. Silverman was. So hi, Prof. I don't know if you remember me. I used to come with Miriam Kaufman and spend quite a few days in clinic there. And this 3-sentence summary really points to having the young person be able to confidently say these 3 sentences. First sentence, age, diagnosis, brief medical history. Then second sentence, what's my treatment plan? I can tell you what I'm on and what's happening with me and what's next. And thirdly, I must be able to tell you any questions or concerns that I want to discuss. So if we can get them to be able to confidently have these 3 sentences set by the time they transfer, we have achieved a lot. Now, self-management is one of the big things we want to make sure that they have under their belt. So their ability to adhere to medication, keep their own clinic appointments, changing them if they need to, adhering to scheduled investigations, and again, communicating with the provider. So what can we do? I mentioned before assessing transition readiness. 2 very common tools which are available freely is the StarX, which is self-management and transition for adulthood, from adolescent to adulthood with treatment. And this is through the University of North Carolina. And then the TRAC questionnaire, which is from the British Columbia Children's Hospital in Canada. So these are 2 tools that are quite helpful, and you can use them intermittently as they go through clinic or through your practice. Next, we want to educate young people. Psychoeducation is a very important tool for them to understand the illness, understand what and how the illness works, how the medications work. And because you said it once when they were 14, doesn't mean that at 15 they're going to remember it. So every time you see them, repeat it again, repeat some of it. Don't be exhaustive, don't be intense and stressful, but just keep going over it, because each time a little bit more is going to stay. And then we want to review the expectations for the adolescent, what they should expect when they move across to the new clinic. Now, many of you here would already be very familiar with the HEAD screening tool, which is really a psychosocial review, because young persons oftentimes as providers, we tend to focus on the medical issues, but we also want to look at all the psychosocial issues that affect and can really either help or impede their progress with a chronic illness. But in addition to these, we want to, I'm just introducing, some of you may have heard of it, but if you hadn't, this is the Threads, which is kind of like a added version to the HEADS, which was developed by the same friend and colleague I mentioned before, Miriam Kaufman, who's this is her area of expertise, transition for the adolescents. And I'm going to walk us through this very quickly. So we should check in with them. What's your condition? How are you doing? And this works for any chronic illness. So you just, adjust it to SLE. Ask them to explain their condition in those same 3 or 4 sentences. Find out how much of their health management is their own responsibility and how much somebody else is doing for them. So is mom the one that's always remembering to take the medication? And what do they need to get ready for adult health care? And what kind of services do you think that this young person will need when they go over? Are there any issues within the house itself that they live in that may affect their health? For example, access to the house if they're in a wheelchair, for example. Do you have concerns about how the condition is affecting the family? Is it interfering with sibling relationships, with parental relationships, with marital relationships? Who else have they been able to share their condition with, and how was that received when they shared it? And if they live in more than one home, not unusual for our young people, how is it easier or harder in each home, and how can we help with that? They should know the names of the medications, no matter how complicated the names are. They should know what the dosages are. And we want to know who's in charge of it. Where is it stored? Who remembers to take it? And how does their treatment regime change depending on if they have an extracurricular activity, or if they have to go to a sleepover, or they're going to go and visit a friend? Are they too embarrassed to walk with all of their medications? And how can we work around those sorts of things? What do they do when they miss a dose? And then find out what are the things that they like or dislike about the medication. And some of them you may not expect to hear, and that's why we have to ask, okay? Don't assume that we know what they're having. I think some of this was gone through before with the previous speaker, so I'll skip on that. We also want to ask a little bit about how SLE impairs or helps or affects their eating patterns and their school patterns. How often do they have to miss school? Do they have a friend that they can get notes from? Or is it really a bother to be able to try and ask somebody for that? How are they coping with the changes in their body appearance? All adolescents have challenges with body satisfaction. And so it's that much harder for young people living with a chronic illness that affects their appearance. Ask about how they're feeling. I'm quite sure Dr. Gillian Lowe is going to talk a little bit more about that. But just quickly to mention that, you know, you only need to ask 2 questions about their anxiety so that you can decide, do I need to refer on? And about their depression, sorry, I went back ways, to find out what's going on. And if they score 3 or more, you want to refer them on if you feel that you cannot manage this, okay? All adolescents are at risk of depression and anxiety, probably as the 2 most common challenges. And so just imagine that added stress of having a long-term illness. And then medications and substances that they may use otherwise. So what do they know about the effect that a substance that they may use, whether alcohol, marijuana, whatever it may be, how does that affect their condition itself, as well as the medications they're on? And, you know, see if they're self-medicating as well. What do they know about how their illness impacts their sexual health? What do we know about it? We need to ask them. We need to talk with them about what contraceptives might be most ideal, most appropriate. For those young women who are living with lupus, we generally will recommend one of the long-acting reversible contraceptives, whether it be intrauterine or subdermal. And then we also want to talk about genetics, because some young persons, when they're getting to that 17, 18, 19 years of age, they start to think about, you know, how is this going to impact my ability to have a family, and what is the likelihood of me having a patient who has this child, son or daughter, with a similar concern. And then we also want to consider the patient's level of emotional support that they have. So what's the level of parental and caregiver involvement? We don't want too much, so we don't want the parents that are kind of hovering and can't let go, and that can be very hard with childhood onset SLE, because parents have probably gone through some very scary periods of time, but we have to allow them to let go. Slowly but surely, they have to let go. And then on the other hand, we don't want the parent who's now frustrated and just can't be bothered because, listen, man, you reach 18 and I'm done. We don't want that either. So we want a good balance of slowly releasing that those boundaries and handing over the reins. Want to look at their level of peer support. It was mentioned earlier also that peer support groups can be very helpful, and also professional support, whether through individual or group therapy, can really make a humongous difference. And then lastly, I would urge you to just listen to the adolescent, listen to what they're saying, listen to what they're not saying, and listen to their nonverbal conversation with you. So one of our exceptional young pediatricians did some work with young adults living with HIV who had done their transition to the adult clinic. And so I just want to share the recommendations that those young persons had said to us. And though this was from young people with HIV, I have no doubt that it is true for all young people. So they want patients to receive counseling in the pediatric clinic prior to transfer, letting them know what to expect. They want to be afforded the opportunity to develop rapport with the adult provider beforehand. So either they go over there for like a site visit or a little outing, or the adult provider can come to the pediatric clinic and meet them. And they would like assistance with making the first adult clinic appointment, and even more so if they can have a pediatric nurse accompany them for the first visit. I would pause here to say we don't have a national policy currently on transition for young people with chronic illness, but I am working along with the Ministry of Health and Wellness as we speak on a policy for the adolescents living with HIV, and our hope is to use that as a starting point. And once we've piloted that and made sure that it works, then the intention is for us to be able to expand that transition policy to all young persons with a chronic illness. So we're getting there. We will soon be there. Hang tight and we'll soon have it to help everybody. And I end here with just giving you some options for resources. All of these are free spaces on the internet that you can look at. And actually, once you just put in transition, it's pretty easy to find stuff that would be very helpful for you until we have our own policy guidelines. And with that, I thank you for your attention, and I'm happy to take any questions if we have time. If not, I'll answer in the Q&A. Thanks.
Thank you so much, Dr. Harrison. I really enjoyed that talk. You answered so many questions that for us adult rheumatologists, we struggle, how are we doing this? And I hope that we can kind of bring back this discussion and have a whole session on this and really find ways to be relevant to our adolescents. You gave us those 3 questions that adolescents need to be able to answer to be ready to transition. I thought that was brilliant. I hope that you'll be able to put that in the chat for everybody.
Okay, will do. Okay.
Because yes, it's reassuring in a way that my expectations are not too high. But I think that I think it's we really have to understand how the capacity of our young people when we give them the chance to really be active. Yes. So and now I learned a term from Dr. Peter Gay Scott Brown. I learned heads. I just learned heads and now it's threads.
Yeah, so, just a little extra oomph.
Yes, that was so good. That was so excellent. You've addressed a lot of things. I know that the time has gone very tight, but my mind is working in terms of the number of ways that we can take this forward. Even as a foundation, because we've made a lot of efforts to engage young people more and they're participating. So we want to start seeing how we can help implementing all these things. And we so value this time with you pediatricians. What's the number one thing you want to tell adult rheumatologists? You told us a lot already, but what's the number one take-home thing that you tell us?
I would say never be afraid to ask the adolescent. Don't doubt that they're going to answer you. I think they just want the space and to know that you actually want to hear what their perspective is. So ask and then follow through on what they've said.
Ask and follow through. They know they can speak for themselves.
They can. They're the best at it. They're their own best advocates.
Yes. And, we've learned a lot because we've seen where that can go both ways. And, they can make their own minds not to take things. Absolutely. And then and they can also be part of the solution as well. And that makes all the difference. We talk about outcomes, and this is really what we're all here about. And this is just such a lovely supplement to what Dr. Silverman brought to us. And it reminds me of when I first met you at Sick Kids.
Yes.
Back in the day, and in that clinic.
Clinic.
Yes. So it's all coming back full circle, Prof Silverman. And here we go. So thank you so much for joining us. We want to ask everybody, if you have questions, just to drop them in the chat. And as before we close off, I know that Dr. Harrison will just check and try to respond to those. But this is not the last we've heard from her, because she's going to have so much to teach us from that program she's doing at the Ministry of Health. So we really look forward to it spilling over into our section. We've been, with Peter Gay, as you used to do a sort of informal transition, and that was really helpful. So hopefully more to come. Thank you very much.
Thanks again.
Thank you. And now I hand over back to, thank you everybody, hand back over to our host, our MC, Mr. Pete Smith.
Thank you very much. Thank you very much, Dr. Tollery. As a matter of fact, you couldn't have said it better. I don't know how Dr. Harrison was able to pack in so much information. She had me pretty much spellbound and watching everything. And one of the things, as you rightly said, respect the adolescent perspective. I think that's a very key takeaway. I certainly have taken that away with me, and I have learned quite a lot about that whole aspect of treating with it and dealing with them. Thank you very much, Dr. Abigail Harrison. I certainly believe that there's a lot more that we could get from you, but again, because of time. So we will be moving very quickly into a short patient perspective film. This film will sort of give you a bit of a highlight as to what a number of our lupus warriors have gone through, how they feel. And I'd like to know, introduce, we may actually have to truncate it a bit because of the time factor, but I think you want to watch it. You don't want to miss this part. Again, thank you very much again, Dr. Harrison, Dr. Tollery, excellent review. We didn't have a long question and answer, but I think we're going to take all the questions in the chat. Let us know how the video. I don't think you want to miss this one.
Hi, my name is Jada Marie Graham, and I am 19 years old, and I have lupus.
Hello, my name is Umiko Chin. I'm a final year student at the University of the West Indies, and I have lupus.
Hi, my name is Kiana Jackson, and I'm 19 years of age. I was diagnosed with lupus when I was 15 years old.
Hello everyone, my name is Rishan Brown. I'm 14 years old. I attend Meadowbrook High School. I'm in grade 9. Lupus has affected me a lot.
I've been fighting lupus for 5 years now. I was diagnosed with lupus in 2016 at the age of 15 years old. Leading up to me being diagnosed with lupus, I would have, my symptoms were having constant headaches, hair loss, swelling in the joints, my knees, my hands. If I stand too long, it would be a problem. If I writing, it would be a problem.
Okay, so I was diagnosed at 16. A lot of things are still a blur, but from what I can remember is I suddenly got sick. I kept throwing up. Just throwing up. Everything I ate just kept coming up. And I took a trip to the doctor. Now, the doctor said that it was probably meningitis or some other things I don't remember, but I know I took a series of tests and I was told that it's not lupus. It's probably just a stomach bug or something. And I went home and I kept throwing up again, and I saw a kidney specialist, and then I did a ANA test, and then it came out negative.
Just getting fatigued, exhausted by just even doing the little things was of concern to my parents. So one day I got up, it was a Saturday morning, and I had rashes. And then we went to our general doctor, and she, did the regular general checkups and stuff, and then she said that the rashes are of concern for her and she's going to recommend me to see a rheumatologist.
Lupus, well, for me, it was always letting my joints swell up. I always feel pains. Sometimes I would ask my mother, she would always ask me if I hit it up or anything. I was like, no, I didn't, and she was so confused. And that was happening for years. And she was really concerned, as any parent would be.
Yeah, Wednesday after school, went to see the rheumatologist, Dr. Stacy Davis. She was asking me if I ever heard of lupus, and I was like, no, doctor, what is that? And then when she began to explain and blah, she began to explain and she began to tell us what it is, and all my symptoms was aligned with what she was saying. And then all the blood tests for the blood work that I did before visiting her, they all came back positive for lupus.
I remember going back to the Turks and Caicos Islands where I'm coming from, and I remember passing out one night. I went to the hospital there, and then the last thing I remember was being flown into Jamaica to the University of the West Indies, where I met a rheumatologist, Dr. Maloney. And that's when I found out, yes, it is indeed lupus. And I was further treated for that.
I did not know what lupus was. I had lymph nodes, I was experiencing joint pain, fatigue, and I was tested for cancer. And the test came back negative. A few months later, I had the lymph nodes reappearing, and then I met my rheumatologist, and she told me that I had lupus.
Blood tests, just have to do now to check the levels, but before it was really a blood test checking for any and everything to really see what was going on. You know, it was kind of sad because at such a young age I had a lot of limitations and things, and I finally found out I had a lot of limitations to things I can do. You know, when you're that young, you want to be out and about in the sun, playing all day long. And if something like that comes up, that's we're basically allergic to the sun, you know, that really affects you.
Because of my lupus challenges and stuff, when it was exam time, I had a lot of flare days during exam time. So while I'm in exam, I having memory loss, like nothing not coming to me, brain fog, like. So as a result of that, I did not pass any of my CXC subjects. And for me, that experience was really devastating because I am not a failing student. And that was really traumatizing for me. And yeah, it's difficult. I mean, I don't wish this illness upon anyone.
Since then, it's been a struggle trying to understand my disease, trying to cope with it. I've been into the hospital several times, but I'm still here. Presently, it's way easier because I understand my disease. I understand when to listen to my body. I know my limits, even though, I go over them sometimes. I do know them and I do understand them. I know how to cope with certain situations. One of the worst things it is that there is to live with lupus now is basically being in spaces where the disease is not understood. It's really difficult because a lot of people don't accept it. They believe you're lying, and so that creates a lot of emotional struggle for me.
I have decided to not let lupus and my circumstances define who I am. I try to think positive always and fight with everything within me.
I have a love for sports and football, things like that. So I tend to be in the sun a lot. And especially lupus, that isn't very good. Being in the sun a lot overall isn't good for you. And having lupus makes it worse. But I think there is something to learn from this, because especially if I want to be a footballer, and football have to have diets and those things, so learning those things and how to keep it under control from now will help me in the future, so that way I can always eat.
After I found out I had lupus, I realized that I had to make a few life changes. I had to change my diet. I could no longer do the things a normal teenager could, which is, stay out in the sun as long as I want to, drink certain things, eat certain things. I was always tired, so I knew I couldn't go out as much, basically. Over time, I got over the fact that I'll never be the same again. So I just accepted it and I changed my life for the better. what I did was, yeah, so after accepting all of that, I started eating better, I started exercising, I started taking my meds, more vitamins, and over time, my lupus improved. I was no longer on prednisone. I am currently just on hydroxyquine and vitamins. I'm doing pretty well in school. I just have to stay focused. And by doing that, I have to stay on top of my vitamins. I have to, continue to exercise. Even though, university comes with a lot of stress, I have to remember that I have to just balance everything out. And so far, so good. I've been a member at the Lupus Foundation.
I definitely would want to invite everyone to catch part 2 of our patient's perspective video on our YouTube page at Lupus Foundation Jamaica. So to catch part 2 of this really excellent video, which speaks to the voices of lupus warriors living with lupus as a youth, go to our YouTube page and you will be able to get part 2. In fact, you'll be able to get both parts, but you definitely want to check that out very soon. In fact, this evening, if you don't mind. So I'd like to thank again Dr. Carol DeCula, our consultant rheumatologist, and of course, our president emeritus, certainly the longest serving president of the Lupus Foundation of Jamaica. Thank you very much, Dr. DeCula, for your contributions and your support. Right now, we're going to move very quickly into section 5. And section 5, we'll have our moderator, Miss Vivette Swaby. Now, Miss Vivette Swaby is going to be speaking to us. She is the educational psychologist from the Ministry of Education, Youth and Information, and she'll be speaking to us on making the difference in the child adolescent with lupus. So let me invite, at this time, Ms. Vivette Swaby.
Okay, good afternoon. I'm truly happy to be here to be sharing in this symposium at this time. And since time is against us, I'll just move quickly into our proceedings. We have on our panel a group of individuals who are quite knowledgeable in their areas of expertise, and will be guiding us through a holistic approach to practical as well as immediate solutions and resources based on various situations that children or youth with lupus and their families may encounter. As well, they will be offering insight on how to access support within the school, the home, the community, and in the healthcare settings. So they'll be given 5 minutes each to present on their different areas, after which the floor will be open to question and answer, and we'll have a little discussion as we go along. Our first presenter will be Dr. Gillian Lowe. She's in the child and adolescent she's a child and adolescent psychiatrist at the University of the West Indies. Her topic for presentation will be promoting resilience, and this is as it relates to mental health as well as home setting. Afterwards, we'll have Professor Earl Silverman, and you'd have seen him earlier. So he's the Professor Emeritus Pediatrics and Rheumatology, University of Toronto, and he'll be presenting on making the difference in the healthcare setting. Then we'll have Dr. Marcia Smalling. She's a principal at Glenmuir High, and she'll be presenting on making the difference at school. And our final presenter will be Mr. Joel Hardin, and he's a medical social worker at the University Hospital of the West Indies, and he'll present on making the difference with state and community resources. Now, Dr. Gillian Lowe had to leave, so we'll now have her recording presented. Afterwards, Professor Earl Silverman will give his presentation.
Good afternoon, everyone. My name is Dr. Gillian Lowe. I'm a child and adolescent psychiatrist, and I am one of the panelists for the discussion this afternoon. I'll be talking to you a little bit before the panel discussion on the topic of promoting resilience regarding lupus, mental health, and the family setting. Now, lupus can profoundly affect a child's mental and emotional health. They are likely to have experienced both psychological and physiological issues, such as difficulty concentrating and poor sleeping. They are also likely to feel emotions like fear, worry, distress, despair, and depression. The process of resilience develops when someone is able to successfully adapt despite challenging or threatening circumstances. And so persons develop an internal state of well-being or are effective at functioning in the environment despite having these challenges. Now, if we consider the issue of pain and lupus, pain and other symptoms such as weakness can make it difficult for a child to do things, even things that they once enjoyed. The disease may make them not able to go to school or socialize with their friends. As with any chronic illness, there is uncertainty about the future, and it may disrupt their sleep pattern. So caring for a child with a chronic illness like lupus places a significant stressor on family members, especially caregivers. There is also the issue of cognitive dysfunction which occurs, and some patients say they are fuzzy-headed. We loosely refer to the term as lupus fog. Lupus fog often coincides with periods of increased disease activity or flares, and cognitive problems can also be associated with depression. So, how does lupus affect children at different stages of development? Well, at the preschool stage, which is from around age 3 to 6 years old, they can exhibit aggression. They may think that the illness is some form of punishment for doing wrong, and it is important to let them know that there's nothing that they have done wrong that is causing this illness. So reassurance is very important for them at this stage. For children who are school age, that is age 6 to 12 years old, it can affect their level of independence, causing them to feel inadequate. And they may develop poor self-esteem, especially if they're not doing well in school or missing a lot of school. Also, the presence and approval of their friends is very important at this stage of development. And the illness separates them from their friends, leading to distress and possible depression. For the adolescence is a time when teenagers want to fit in with their peers. However, having a chronic illness like lupus can cause them to gain weight or have significant hair loss or have skin lesions which are unattractive or have medication side effects, and all of these undermine their social life and again lead to distress and possible depression. Now, with regard to depression and lupus, it can occur as a psychological reaction to having the illness, part of the disease process itself, or as a side effect of medications. So people with lupus may experience unpredictable changes in their mood and personality traits. They may also have feelings of anger and irritability, all symptoms of depression. So how do patients with lupus affect their family? Persons with lupus may feel guilty about not being able to do the things that they once did. They may feel unhappy about the accommodations that other family members may be making on their behalf, and their siblings may be jealous of the fact that they may be getting attention all the time. How can we help our children who have lupus? Well, it's important to educate them about the illness. For example, what makes the symptoms worse? ultraviolet rays from the sun or fluorescent light, any form of infection, exhaustion, physical or emotional stress or distress, having low vitamin D levels, and exposure to secondhand smoking, especially cigarette smoking. So how can children help to manage their own symptoms? Well, they need to be aware of what makes it worse, as we outlined earlier, and then make the necessary accommodations, such as using sunscreen with SPF 30 or higher, and wear sun protective clothing, such as wide-rimmed hats, long-sleeve shirts, and pants. Wash their hands often to avoid any contagious illnesses like the common cold or flu or coronavirus. Ask for help when they need it. Take a break when they feel tired or stressed. Tell an adult when they're not feeling well. So what are good lifestyle changes for children? The family is so important in this process, and family support in any lifelong illness is key to managing this condition. It's important to encourage the children to take all their medications as prescribed, attend all their health clinics, and follow the doctor's instructions. Eat a healthy diet, which is full of fruits and vegetables and high fiber. Exercise regularly. Get enough sleep. Aim for at least 9 hours per night. Take breaks during the day or rest and recover. And plan outdoor activities in the early morning or in the late evening to avoid too much ultraviolet light exposure.
Okay, so now having heard from Dr. Lowe, we'll now ask Professor Silverman to share with us on making the difference in the healthcare setting. So over to you, Professor.
Okay, thank you. So you've heard a lot from people of how to really treat patients with lupus. And I think the whole issue, and you've sort of heard it because you've heard from dermatologists, nephrologists, psychologists, pharmacists, and adolescent medicine specialists. And that's the key. I think you have to use a holistic approach. You know, we talked about, and I talked about adherence, and it's one thing for me to say you should take your medicine, but when you have a team combined, and I think in a city that's big, as some cities in Jamaica are, and certainly Toronto, and when you can have enough patients together, I think it is worthwhile to have a dedicated lupus clinic. I think we're dealing with a disease that differs so much from anything else, and you need an expertise in this that is very, very difficult to do without seeing tens, hundreds of patients. So I think the key at the hospital really is to have a nurse who knows about lupus, helps you with education. We are fortunate enough, as you heard, that we have adolescent medicine who come to our clinic every single time. They deal with adherence, they deal with sexuality, which is huge in adolescent females. They deal with transition, they deal with all the heads. And those things are just so important that nobody can do everything. We were fortunate, you heard from us, a pharmacist. At one point, we were fortunate enough to have a pharmacist. Unfortunately, they didn't have time, but that really increased adherence to medication. Psychology and or psychiatry, we have a dedicated psychiatrist. You heard from dermatology. We have a dermatologist who has a clinic not with us, but parallel to us. So just up the hallway, and the clinic is combined with a nephrologist. So I think at the hospital, you have to look at the whole patient, use all your expertise, because this is a very labor-intensive group of people if we want to really change the outcomes and really support them. You heard of all these, there's so many psychological issues. I think we miss depression more than we think we do. The pandemic has just exacerbated it. So I think from a hospital point of view, my feeling is simple. If at all possible, have a specialty clinic. And the other thing it does is it makes the people who come to it not feel different. It's one thing to be in a room with other general pediatric patients, or even in a rheumatology clinic with other rheumatology patients, but they don't have lupus. But to be in a clinic where everybody has the same disease that you have makes you not so different. And so I think that's the take-home message, if at all possible, and reach out. And if you can get support, which we have had from Lupus Ontario for our clinic at times to get it going, that would be fantastic. So thank you.
Thank you so much, Professor. Well said. So now we'll just invite Dr. Marsha Smalling to give us her presentation on making the difference at school.
Good afternoon, good morning to our chairman, Mr. Pete Smith, Reverend Verna Castles, President Dr. Desiree Toller-Reed, our keynote speaker, Professor Earl Silverman, our moderators, presenters, our lupus warriors, or may I say, my fellow lupus warriors. It is great being here to address you today in my capacity as an educator of Glenmuir High School, of course. I have been benefiting from the different presentations, and there's definitely going to be some overlap, but I'll try my best not to repeat some of the things at all. So let's go. The belief that I am not alone builds confidence, hope, and optimism, and gives you the mental fortitude to fight your fears. This was and still is my experience, and that of many others, including our children who are battling this condition. Now, the slogan of the Ministry of Education, Youth, and Information is that every child can learn and every child must learn. And as educators, as school leaders, we do embrace this slogan. We know, therefore, that we must build a healthy and supportive learning environment for our children and youth affected by lupus. The severe symptoms and side effects of some of the medicines can affect these students. My personal experience living with lupus, as when I was first diagnosed in 2003, I had started my bachelor's degree and was able to move on to earning my master's and PhD. Of course, while serving as a classroom teacher and subsequently as a school principal in 2009. I experienced the fatigue, still do, the periodic pain, which sometimes was just so unpredictable, the loss of appetite, loss of my hair, trouble concentrating and remembering, and the swollen feet. A strong support system at home, work, and school propelled me to achieve my goals and to not only survive, but to thrive in spite of this condition. This, of course, gives me a better understanding of how to treat students and how to encourage my fellow educators, how to provide support for these children. I still remember personally a few of my professors, batchmates, and other support staff assisting me to get through the days. The late Dr. Herman Dose would carry my laptop and lunch bag with when we had to transition from one classroom to another. Dr. Henrietta Green would meet me at my car some mornings to assist me in taking my carry-on to my seat. I remember the healthy snacks that Dr. Dose would take for me during the days. A strong support system supplements the medicine we need to thrive, that they need to thrive. The combined efforts of our guidance counselors, administrators, school chaplains, form teachers, grade coordinators, subject teachers, and other stakeholders can raise awareness about lupus and facilitate the growth and development of our students. We are always willing and ready to do our best to make our children believe they are not alone. Some of the symptoms, as I've mentioned before, that affect our students, and I can speak specifically about Glenmere because there are a few students at school who are living with the condition. I recently accepted another one because I felt I needed her to be under my care so that I can offer greater support to her. The fatigue, feeling very tired easily, the painful or swollen joints, the swelling of the hands, feet, and around the eyes, sores in the mouth and nose, the butterfly-shaped rashes on the cheeks and nose, the hair loss, trouble concentrating or remembering, as I mentioned before. And how does lupus affect our students in school? The regular absenteeism, tardiness, low rate of participation in extracurricular activities, and these are in severe cases. Social isolation and teasing will happen in some schools, and changes in physical appearance. And there was a presenter who spoke about the fact that when students get to a particular age, they are now impacted with self-esteem, self-confidence, self-awareness challenges. And so we have to pay keen attention to that. So body image, academic performance, and emotional and social welfare of our students. What's the role of the school in all of this? Because we want the students to feel, to believe that they are not alone on this journey. And therefore, we have to ensure that our actions are in alignment with our words. So it's not just enough to say we care. It's not just enough to say we are compassionate. It's not just enough to say that we understand what you're going through. We have to demonstrate through our actions what our words indicated. So we must raise awareness about lupus. We must adjust our curriculum to facilitate students, and we must build and maintain a support system for them. Who is responsible for doing all of this? And as administrators, I am the accountable officer. So if it is that we believe that every child can learn, every child must learn, if it is we want our students to produce optimal performance, and I can tell you that every school wants their students to be the best versions of themselves, every school, every administrator, all the teachers, we want our students to capitalize on their special gifts and talents as well. The guidance counselors, they play a key role because they would do individual counseling or group counseling, and they are usually the go-to person when the students lack self-esteem, lack self-confidence, they're just not proud of the person they see in the mirror, and it's going to take time for them to get to that place where they accept and embrace themselves. And what I always say to these persons, whether they attend Glenmuir or not, is that they must seek to demonstrate that spirit of gratitude. Because sometimes when you realize that, hey, I am alive, I am not in bed, I am able to walk around, I'm able to attend school, that's so much that these students can be grateful for. Parent Teachers Association, very important, because through that medium, we can be able to build awareness. I mentioned the teachers before, and we can do this through symposiums. Did you know periods during General Assemblies, which takes place every single week, discussions during form time, social media posts, blogs, and just getting the children involved, getting them active, because the more involved they become, they'll take their minds away from the different effects that they are experiencing. How do we make students believe they're not alone? By building healthy, productive learning environment, which encompasses positive relationships. So the teachers, we have a responsibility to ensure that there is no discrimination. We want to inculcate the value that you belong, that you're a part of us, that we must share with each other. And different schools have different core values, and we can always manifest these in the way that we treat these children. One of the things that I'm proudest of as a principal at Glenmuir High School is just how the students rally around students with disabilities. I just marvel at it all the time, and I know that in other schools, this happens as well. The delivery of lessons will play a key role again. Being online, for sure, has its benefits and its downfalls as well. Because when the fatigue hits in, when you have to be seated around your computer for a prolonged period of time, it can really get to these students. But the good thing about it is that lessons are recorded, so they can basically work at their own pace. They can make reference to it a day after, 2 days after, and so on. Provisions to master a subject and the institution of master learning is very important. Just giving the students a second opportunity to learn a concept, to maybe do over a test, depending on their situation. Adjustments must be made to the assessment policy to cater to the needs of the students who are living with lupus. And these are the ones who are severely affected, because some students live basically normal lives in many instances. Just to let you know that for those students who are doing CXC, as long as CXC is made aware of their condition, support can be given. Sometimes students are hospitalized and they're able to do their exams in the hospital. The same for internal assessment. As long as we know ahead of time, we will facilitate their examinations. Modified physical education. So we have the theory and the practical aspect of physical education and sports in school. And in many instances, students have to be out there in the sun, and another presenter spoke about that already, so I'll not get into it. So the teachers must be made aware of the conditions of the students so that they can modify their curriculum and how best to facilitate the content. Extension of time to transition from one class activity to another. And we're moving at a rapid pace. So if a child is a bit late, the teacher will understand that the child may be feeling pain at the time or just may feel a little bit tired. And so they need to understand and demonstrate empathy and compassion there. I spoke about recording lessons for future reference, and I think that is standard in all schools, especially now. And what I can say is that even when we return to face-to-face, we will not abolish online because it has its place. So that is basically my presentation. I want to thank you so much for allowing me. And of course, I am prepared to answer whatever questions you have. Thank you so much.
Thank, thank you, Dr. Smalling. Well said. I must say, and as one being in the Ministry of Education and a part of the Special Needs Department, you know, that was, as I see Dr. Tolleridi saying, very comprehensive because, and I do agree, and the points that were made, these were considerations that I myself had, and I'm not, I hope I don't seem biased, but you know, you really knocked it out of the park and really did a good job in explaining to our parents that they can understand what is there in terms of support within the school system for them, and also what accommodations they can get. But I'll add a little more in my wrapping up later. So now we go on to our final presenter, Mr. Joel Harding. You may go ahead.
Hi, good evening, and all protocols observed. To all the lupus warriors, good evening to you, and to any part of the world you are. Good evening, good morning, good night. All right, so I'm Joel Holding, and looking at making the difference with state and community resources, and looking at state and community, what comes to mind is that Jamaica itself is a pluralistic state, right? And looking at welfare pluralism is that the state and the non-governmental organizations come together to play a very important role in alleviating stress situations and well-being, social welfare. So for me, looking at this really is that what really is an issue is what some of my panelists have mentioned is about the educating, right? And so when you look at education in terms of knowledge about the different welfare assistance that is out there, there is not much persons who know about the different welfare assistance. And so this is where social workers come in to assist in the process. And so I'm going to share with you some of the social welfare systems that are out there that can assist in where you can go and get assistance. And so looking at the University Hospital is another hospital that assists in treatment and care for lupus. And so the cost for first visit would be $2,500 and the follow-up cost would be $1,500. At KPH also does treatment for lupus, and that offers free healthcare, and medication can be very costly. And so we thank NHF for coming on board in alleviating, you know, cost, you understand, in terms of allowing persons to get an NHF card, right, so that they are able to benefit and to get their medication at a subsidized cost, right? Also, the Lupus Foundation as well, they offer their discount card, right? And so it is important for persons to join the Lupus Foundation. And as a social worker, I also recommend patients who I come in contact with and who is living with lupus or diagnosed with lupus to join the foundation, because there are a lot of benefits that comes with joining the foundation, right? Also, blood works are also costly, and at some hospitals, if you're referred to the social worker, then they can assist in waiving some of these costs, right? If receiving treatment from the public setting, then you are privy. You're very much privy to a social worker, right? And so that social worker can assist you in linking you and navigating you through different agencies that will offer assistance, financial assistance, and some of these agencies can include PATH, Poor Relief, and they will assist you with medication, paying for medical bills, and you name them, right? And so when you look also at the Ministry of Health and Wellness, they do offer compassionate grant, as well as the Ministry of Labor and Social Security. They offer special grants. Apart from PATH and Poor Relief, they offer special grants as well, right? If you are unable to function, right? So once you were able to function, but now you're unable to, then what can be done is that we can link you to the Jamaica Council for Persons with Disability, right? And who will register and cover some of the cost of your medical bills, right? And even assisting in starting a small business grant and whatever venture that you are, you know, what you would like to do. And based on our assessment as social worker, counseling and intake and building rapport during the helping process, right? Then we're able to work with you based on your goals and all of that, right? And so I would recommend again the Lupus Foundation for persons, right? Anybody, adolescents, adults, to join the Lupus Foundation because it provides support group. And when you are an adolescent, right, you need that support. You need that adequate support for persons to listen, for you to talk, for you to share, for you to vent, because there are times when this come on you and you are wondering, what did I do wrong? Did I say something wrong? Did I do somebody wrong? You understand, for this illness to take me as a young person. And it provides an open space that you can share with your peers. You can hear from other warriors who are struggling with the illness and how you are able to overcome. And so it is very important for persons to build a network and to have a network, and that special network is the Lupus Foundation of Jamaica. Thank you.
And thank you to Mr. Holding. Again, this was also very informative and a lot of information. And I myself was taking notes. I'm not sure how many persons were, but as I said, this information will be available on the website, because I'm sure there are things that persons are hearing for the very first time and would have been interested in knowing, what could I do? What else can I do? What is out there? What is available to me? And at least, and as I said, too, one of the more important things is to align yourself with the Lupus Foundation, because at least you'll get more information. And I mean, with your diagnosis, to be in contact with your doctor, you know, to have your social worker, because that again was another of my concerns, that yes, we have counseling that is available, but then this is not just counseling. Okay, I have poor self-esteem, for example, but this is, I have poor self-esteem because of what I'm going through because of my diagnosis. So I need somebody to be able to understand, to be able to guide me, not just how to build self-esteem, but to understand where I'm coming from. It is because of living with lupus. It's because of these rashes are coming out. It's because of these aches and pains and everything that goes with it that I am going through and I am feeling. I need somebody who can understand that and relate to me, and not just a counselor for the sake of. And no, I'm not underscoring or in any way their job or their roles, but I'm certain as someone who understands the illness, you know, they'll be able to better get the support. And I like Professor's suggestion, as he said, you know, having a specialty clinic. You know, I have heard of, oh, we have an eye clinic, we have a clinic for this. It is good, you know, for a specialty clinic. So persons will meet each other even as they sit in the waiting area. You know, there's someone else I can relate to. There's someone else I can talk to about my concerns, what they're going through, what worked for them. I can offer suggestion to someone can offer suggestion to me, and he one of the things he mentioned also was about also, I guess, for healthcare, that a nurse who knows about lupus, because that is it. For individuals, it is better, and you feel better when there's somebody, as I mentioned, even with having a counselor that understands the illness, understands they are better able to relate to you and to encourage you and to see, and we're empathize where necessary or where possible, right? And as Dr. Smalling said too, she really offered a lot of insight and information in terms of the school, the building this healthy and productive environment for our children, giving them this strong support system. And she reiterated though that this strong support, the student needs a strong support system both at home and at school. So it's not just the expectation of the parent to say, look, I send my child out to school and I expect the child to do this. As parents, there is also your role to play. You're the best person that can advocate for your child. No one else can do it except you. And if you put in little, you can only expect a small return, right? And I'll add, time is going, I need to even wrap up my wrapping up, but also the school support that is required. Yes, we have the need the guidance counselor involved, the administrator, as she said, chaplain, teachers, which covers, yes, the grade supervisor or the form teacher. Everyone has to play a part, because the physical education teacher, and as she mentioned also about, what can be done or what needs to be done in terms of modifying the physical education. There are things also, giving them extra breaks. I suggest in the school system, we can have possibly like a buddy system. There's somebody that someone is assigned to them. It can be something that is rostered, that you always look out for this person. With the parent, you have the discussion with the school. What happens when my child misses school? Can we get the recording? Can we get the notes? Who can take the notes? That, as I said, the child feels that, yes, I'm a part of something and I am feeling my support. And let me not leave out then in my final wrapping up, and as it relates to accommodations, Dr. Smalling mentioned about CXCs, but also we have our national exams. So like for the younger children, especially then, for PEP, who might be doing PEP, because also with their medical report, it can be sent in through our student assessment unit, that they themselves can also get the necessary accommodation for the national exam, right? And she had already mentioned also for CXCs. So I urge us all, and I thank you, parents. We can only be the best advocate for our children. And yes, as teenagers, they can do things for themselves, but they still need the hand holding and they still need the support. And again, I'll say, thank you so much for this opportunity, and thank you, panelists. Over to you, Dr. Toller-Reid, or to Mr. Smith.
Is back?
Oh,
okay. Well, Mr. Smith is out. Okay, good.
I was sort of wondering why is it that my video wasn't coming on. I had to personally thank Viviet Swaby. I listened very intently and very keenly to what she said, and I thought that her presentation, though a bit truncated, was very good. So that, ladies and gentlemen, was Viviet Swaby, the educational psychologist from the Ministry of Education, Youth and Information. I thank you very much for your presentation. I thought that it really has provoked a lot of thought with me, and I certainly hope that all the young persons here were able to benefit from it as well. Not to mention that the information will be available online as well, as we put it out there for the persons that want to view it on YouTube. So thank you very much again, Ms. Swaby. Much appreciated.
You're welcome, sir. Can I just say one sentence? I forgot. In the Ministry of Education, we have regional special special needs coordinators, and they are in all regions. So I would throw it out whether to parent or even to the school. If you might feel you need some support in terms of maybe might be, we need to get someone just to help us to sensitize the teachers or, or even students how to navigate these situations or any other situation, feel free to contact the special needs coordinator in your region, because we have one in each region. Thank you.
Thank you very much. And I think that's very good and important information that we need to get out there as widely as possible. Thank you very much again, Ms. Swaby. At this point, I know we have had a very full evening, an evening rich with information, as I said before. We had good entertainment, and now we're at a point where we are going to offer the vote of thanks. And for that, I'd like to invite my colleague, our most esteemed colleague, Dr. Desiree Tollereed, who will be moving the vote of thanks for this really auspicious occasion and this great event that we had, the Virtual Lupus Symposium, which I thought was really very rich with information, and I thought touched a number of bases. Dr. Tollereed, how are you doing this evening? It certainly was good.
Yes, I mean, there's so much to take in. There's so much to learn. I just hope, Pete, that, everybody felt like they came away with something. I feel like I've come away with so much.
Oh,
and
I know Pat is full.
And there's so many people to thank that, I had to just find a way to contract a little bit in the interest of time. And of course, we must thank you, our Master of Ceremonies, for ably carrying us through a full day of very varied presentations and very varied content smoothly and masterfully. And so on behalf of the organizing committee, I should actually first thank the organizing committee of the foundation as regards to our symposium. Organizing our symposium, Lupus Foundation is composed of volunteers. And so who've been working hard to have this come off. And so I want to say special thanks to Reverend Verna Castles, who offered our prayer, our representative of the Minister of Health and Wellness, Dr. Nadine Williams, who ably represented, and specifically and especially Professor Emeritus.
Which one?
Professor Earl Silverman, our special guest, who really set the tone for this critical conversation as we talk about outcomes. I do believe that we've received the information that we need and the perspectives that we need to make those outcomes better. And so we want to thank him for, a wonderful and thorough presentation, and for sticking with us and coming on, contributing to the panel in such a practical way. And of course, we have so many excellent presenters to thank. And we're starting from, I don't know if MC will allow me to.
I think I should allow you a couple minutes, yes. We had excellent moderators and presenters.
Okay, if they'll allow me to thank our presenters, Dr. Rebecca Thomas Chen, Dr. Sandrika Young-Peart, and Dr. Donna Braham, Dr. Winsome Christie, Dr. Abigail Harrison for their excellent and informative presentations, ably moderated by our moderators, Dr. Norian Fisher, Dr. Raquel Lowe-Jones, Dr.
Tanisha McGee.
Tanisha
Phillips,
McGee, yes, Phillips.
Got them all
and
started.
Right, and Dr. DeCula, our President Emeritus, we're so sorry we didn't get to hear your voice. I mean, a symposium is not the same. We saw your face and we know you've been here, part of the process, and all these persons are, volunteers of the foundation who constantly give their time, and they've continued in this vein. And we also want to thank our wonderful panelists who in just a short space of time shared so much practical information. I know Miss Swaby has already thanked them for their contributions, Dr. Gillian Lowe, Professor Earl Silverman, Dr. Martha Smalling, Mr. Joel Holding, and Ms. Swaby. Thank you so much for bringing your expertise and perspective and pulling everything together in such an able way. We want to give a special thanks to those wonderful young people.
Oh, yes.
Yes, well, there's so many different wonderful young people, but many contributed
Very
their
talented
creative pieces, made creative pieces to share with us today. The young people, the young students of Music House.
Music House,
and,
yes.
Yes, and our member, our Lupus warrior, Kiana Jackson.
Right.
So we thank you all. And we want to thank all the volunteers, all our young warriors who contributed to the film that we were able to put together from your perspective that you sent in.
Oh, yes,
and,
Georgia, Anna
yes.
Kay,
And to Mr. Kevin
Jada
Jackson.
Marie.
Yes. And
of course, Rashawn.
Yes. And to Mr. Kevin Jackson, who put everything together in such a, it really does tell a story. I really hope everybody has a chance to watch it on YouTube. And of course, behind the scenes, we don't want to keep everybody here, but there was a lot of activity behind the scenes and a whole team of persons. We thank our graphic designer, York Alley Walters. We thank Ezeram, providing multimedia management to make this meeting possible. There are a lot of moving parts.
Yeah.
Yes, and in the back end, there are all the team members who handled registration, payment, or web designers, those who, did the PowerPoints and, like Shari DeRosa, Olga Brown, and of course, our administrative coordinator, Kimon Leach, answering all the registration questions and doing all the troubleshooting in the back end. So there were a lot. I really hope I haven't left anyone out.
Oh, definitely. Did we mention our social media team?
Yes, our social media team. Thank you, Hanifa Patterson, Sherry DeRosa. So much important in getting the message out to this generation. And thank you, all of you who have stuck with us. You've been such a wonderful audience. We're sorry we couldn't hear your voices, but you've been active in the chat, in the Q&A, and you've spent the day. Thank you for all of you who stayed with us. And I know that our MC is going to thank our sponsors, so I have deferred that to him. And we want to thank all the volunteers and members of Lupus Foundation who continue to stick with this organization, some 300 members that come together, speak with one voice, help to support each other, help to sustain the work that the foundation is doing. It's not just patients, it's so many other persons. You don't have to have lupus or to be a health professional. So there's so many people who behind the scenes or board members or volunteers. So thank you so much, everybody. And over to you. And we look forward to seeing you at another symposium next year, whether we're in person or online, and also at our many events, and to following us on our social media pages. And I'll hand over to our moderator to share more. Thank you. Thanks again.
Okay. Well, after Desiree, Dr. Tollery has done such an amazing job with the vote of thanks, there's not much left for me to thank, but to also add my touch to the thank you to our sponsors again. The sponsors, not only for this event, our title sponsors, National Health Fund. They have been a tremendous force within the nation, and they have been a very strong and supporting organization for the Lupus Foundation of Jamaica. We'd like to thank the National Health Fund and all the work that they're doing and that great logistics team that they have. We'd like to thank our gold sponsor, that is IPCA Laboratories, and they have been with us again this year, and they know exactly why they're here. It's a good combination, a good partnership. We'd like to thank our silver sponsors, Wysinco, Dr. Reddy's, and Carimed. Oh yes, these are excellent combinations that we're partnered with, and we believe that the Lupus Foundation and our Lupus members across the island would have benefited from. But it's funny that all of this is within an entire package. called our Lupus Awareness Month, which is celebrated in October. And during that month, we had other events where we had a number of other individuals and other companies. So of course, we had Esteron, we had Imagination, we had a Gleaner Company, and of course, we had Berita Investments, we had Jamaica National Group, oh yes, and we had the National Health Fund, of course, right over there at all times as our title sponsor. We had Grace Foods, and we had Sagicor. These sponsors have done an amazing job in partnering with us, coming with us to ensure that we were able to impart this message, these messages from our exceptionally brilliant and sagacious moderators and presenters. And I think that thank you is not even enough, but we just like to ensure that on record, we thank all our sponsors, all our moderators, all our presenters, and of course, you who stayed with us for the entire day of this rich presentation and program of the virtual symposium by the Lupus Foundation Jamaica. Check us out, lupusfoundationjamaica.org, and you'll always have a lot more information to get by going to our YouTube pages as well. I'd like to thank you very much again and have ourselves a really great Sunday evening. I certainly hope we contributed to the weekend, and that you'll be richly enlightened by what you heard. Thanks again. Have a great evening, and God be with you all. Thanks again, and take care. Good night.